Hello and welcome to your ultimate guide for the ATI Adult exam. My goal today is simple: give you everything you need to fully understand the key concepts, master them, and walk into your ATI Adult exam with total confidence. In this video we'll cover blood transfusions, renal disorders, cardiovascular emergencies, preoperative care, fluid electrolytes. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website offers free exam guides and practice questions to help you ace your ATI Adult exam. You'll find the link in the description below, so be sure to check it out and get the resources you need to study smarter, not harder. So let's get started.
Question 1. A nurse is preparing to transfuse platelets to a client who has a low platelet count. Which of the following statements about this product is accurate? Your options are: A. Platelets must infuse slowly over hours. B. Platelets require a large bore filter only. C. Platelets are cross-matched like red cells. D. Platelets do not require blood type matching. Which one is it? Pause the video if you need more time. The correct answer is D. Platelets do not require blood type matching. D is correct because platelets do not need to be matched to the client's blood type and are infused immediately over a short period using a special set with a small filter, which preserves their function and clotting ability. A is wrong because platelets are given quickly within a short window, not slowly over several hours. A prolonged infusion would let the platelets deteriorate and lose the clotting benefit that the client urgently needs. B is wrong because platelets are administered through a special set with a small filter, not a large bore filter intended for red blood cells. The small filter protects the fragile platelets during their rapid infusion. C is wrong because cross-matching applies to red blood cell containing products to prevent hemolysis. Platelets are an exception and do not need this compatibility testing, so describing them as cross-match misstates how they are prepared. Platelet transfusions follow their own set of rules that often surprise clinicians trained on red cell protocols. Understanding why platelets behave differently starts with what they are and what they do. Platelets are tiny fragments shed by large bone marrow cells called megakaryocytes. When a vessel wall is injured, platelets rush to the site, change shape, and clump together to seal the break, forming the first soft plug before clotting proteins even arrive. Platelets invert nearly every red cell rule. No cross-match is needed, a smaller filter set is used, and the infusion runs fast, over just 30 to 60 minutes. Red cells require cross-matching, a large bore filter, and a slow infusion lasting up to 4 hours. Platelets are extraordinarily fragile. They are kept at room temperature with constant gentle agitation, and they last only about 5 days. Running them in quickly is not impatience. It is deliberate, because a slow drip allows the fragile fragments to clump and die before reaching the patient. On an exam, a low platelet count paired with a fast infusion and a special filter set is the signature of platelet therapy. Keeping the platelet and red cell profiles separate, rather than applying one universal transfusion rule, is what makes this concept click under pressure. Question 2. A nurse is planning care for a client who has polycystic kidney disease. Which of the following actions is the highest priority? Your options are: A. Controlling the client's blood pressure. B. Encouraging high-impact exercise. C. Restricting all dietary fiber. D. Limiting fluids to prevent cyst growth. Take a second. Which answer would you pick? The correct answer is A. Controlling the client's blood pressure. A is correct because controlling blood pressure is the highest priority in polycystic kidney disease because hypertension from cyst-related ischemia accelerates kidney damage. Managing it protects remaining function, so the nurse focuses care on keeping blood pressure within target. B is wrong because high-impact exercise risks injuring enlarged cyst-filled kidneys and could rupture a cyst. Rather than a priority, vigorous activity poses a hazard, so the focus stays on blood pressure control instead of strenuous exercise. C is wrong because fiber is actually encouraged to prevent the constipation common in this disorder, so restricting it is counterproductive. This action addresses the wrong concern entirely, while blood pressure control targets the real threat to kidney function. D is wrong because fluids are generally encouraged, not limited, and restricting them does not stop cyst growth. The misconception that fluid restriction helps overlooks the true priority, which is managing the hypertension that drives progressive kidney damage. Polycystic kidney disease is a genetic disorder where fluid-filled cysts slowly replace healthy kidney tissue over decades. Understanding how it works and what actually drives long-term damage is the key to managing it well. In a healthy kidney, tightly packed tubules filter waste and balance electrolytes. In PKD, a genetic mutation disrupts the proteins that keep tubules properly shaped, causing them to balloon into cysts. Over time, hundreds of cysts crowd out the working tissue, and the kidneys can grow to several times their normal size. PKD follows an autosomal dominant inheritance pattern, meaning a child needs only one copy of the faulty gene from one parent to develop the disease. This is why PKD runs in families, and why symptoms typically surface in adulthood rather than at birth. There is no cure for a structural flaw written into the cells. Management focuses on slowing the damage. As cysts enlarge, they compress nearby blood vessels, reducing local blood flow. The kidney interprets this as low pressure and activates the renin-angiotensin-aldosterone system, raising blood pressure to restore flow. That elevated pressure then damages remaining healthy tissue, worsening the very ischemia that started the cycle, a self-feeding loop that begins early, often before kidney function visibly declines. PKD produces many problems: anxiety, flank pain, blood in the urine, and kidney stones. But the single intervention that most changes the long-term outcome is controlling blood pressure. Lowering pressure slows the loss of kidney function more than anything else short of dialysis or transplant. When the scenario points to hypertension in a PKD patient, that is always the priority thread to follow. Question 3. A nurse is caring for a client who has a known abdominal aortic aneurysm and notes a pulsating mass in the abdomen. Which of the following actions should the nurse take? Your options are: A. Palpate the mass to estimate its size. B. Apply firm pressure over the mass. C. Auscultate while pressing on the mass. D. Avoid palpating the abdominal mass. Before I reveal it, which one do you think is right? The correct answer is D. Avoid palpating the abdominal mass. D is correct because the nurse should avoid palpating a pulsating abdominal mass because pressure can provoke rupture of the weakened aortic wall. A ruptured aneurysm causes massive hemorrhage, so the mass is monitored without manual manipulation. A is wrong because palpating the mass to gauge its size endangers the client because manipulation of the fragile, dilated aorta can trigger a fatal rupture. Sizing is done with imaging studies, never by pressing on the aneurysm itself. B is wrong because applying firm pressure over the aneurysm directly risks rupturing the weakened wall and causing catastrophic bleeding. The correct approach is to avoid touching the mass, allowing imaging rather than pressure to evaluate it safely. C is wrong because pressing on the mass to auscultate still applies the very force that can rupture the aneurysm. Any manipulation is hazardous, so the nurse should refrain from palpation altogether rather than combine it with listening. The aorta carries oxygen-rich blood from the heart through the chest and abdomen. When a section of its wall weakens and balloons outward, that is an abdominal aortic aneurysm, and the rules for assessing it are unlike almost any other abdominal finding. The aneurysm wall has thinned and stretched under years of pressure. High blood pressure, atherosclerosis, smoking, and inherited connective tissue weakness all erode the vessel wall over time. Once dilation begins, a wider vessel carries greater wall tension at the same pressure, so the bulge tends to grow faster as it enlarges. Think of an old tire with one weak spot. The more pressure builds, the faster that spot balloons, and the wall becomes steadily more fragile. A rupture of the aorta releases blood faster than a tear in almost any other vessel, making it immediately life-threatening. When a pulsating midline abdominal mass is suspected to be an aneurysm, assessment must run through the eyes and through imaging, never through deep pressure. Ultrasound and CT size the vessel without touching it. Deep palpation can convert a stable aneurysm into a ruptured one within seconds. Most physical assessment rewards careful hands-on examination. This is the critical exception. When a pulsating aortic mass is present, restraint is the skill. Keep hands off, control blood pressure, and let imaging do the work. Question 4. A nurse is reviewing preoperative laboratory results for a client scheduled for surgery. Which of the following values should the nurse report to the provider? Your options are A potassium level within the expected range, B, a sodium level within the expected range, C, an elevated white blood cell count, D, a hematocrit within the expected range. What's your answer? Commit to one before I continue. The correct answer is C, an elevated white blood cell count. C is correct because an elevated white blood cell count suggests infection and should be reported before surgery. Other abnormal results, such as a high creatinine or high glucose, also warrant notifying the provider preoperatively. A is wrong because a potassium level within the expected range is normal and needs no report. The nurse alerts the provider only to abnormal preoperative findings, so a value in range does not require notification. B is wrong because a sodium level within the expected range reflects normal status and is not a concern. Reporting focuses on values signaling infection or organ impairment, which a normal sodium does not represent. D is wrong because a hematocrit within the expected range indicates no immediate preoperative problem. Because it is normal, it does not meet the criteria for the abnormal results that should prompt notifying the provider. Before any surgery, a focused panel of lab tests acts as a safety checkpoint, confirming the body can handle anesthesia, blood loss, and the stress of healing. The goal is to catch hidden problems while there is still time to act. The panel gives a snapshot across 5 key areas: oxygen carrying capacity, electrolyte balance, clotting ability, signs of infection or inflammation, and kidney function. Any one of these, if impaired, can turn a routine procedure into an emergency. A white blood cell count normally runs between about 5,000 and 10,000 per microliter. When it climbs above that upper limit, the body is likely fighting infection or inflammation, and operating in that state raises the risk of poor wound healing and even sepsis. The key discipline is simple. Values within their expected range are background reassurance and need no special action. Only results that fall outside the normal range and carry surgical risk, like an elevated white count, high creatinine, or abnormal clotting time, should be reported to the provider before the procedure goes forward. On an exam, the classic setup is a cluster of normal results alongside one that stands apart. The discipline is to identify that single outlier and understand why it matters, not to flag everything, which buries the real finding in noise. Question 5. A nurse is caring for a client during the emergent phase of a major burn whose urine output has dropped below the target. Which of the following actions should the nurse anticipate? Your options are A. Administering a diuretic, B. Restricting the client's fluid intake, C. Withholding intravenous fluids, D. Increasing the rate of IV fluids. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Increasing the rate of IV fluids. D is correct because during burn resuscitation, a falling urine output reflects inadequate fluid volume from capillary leak. So the nurse anticipates increasing the IV fluid rate. Restoring volume improves perfusion and brings urine output back toward the target. A is wrong because a diuretic is not given for low urine output during burn resuscitation because the problem is volume depletion, not fluid overload. Forcing diuresis would worsen the deficit, so increasing fluids, not removing them, is correct. B is wrong because restricting intake during the emergent phase would deepen the hypovolemia caused by massive fluid shifts into the tissues. The client needs more volume to maintain perfusion, making fluid restriction the opposite of the right response. C is wrong because withholding intravenous fluids removes the very treatment that corrects the low output and supports circulation in a major burn. Stopping fluids would accelerate shock rather than restore the urine output toward its goal. In the first 24 to 48 hours after a major burn, the body undergoes a dramatic fluid shift that defines care during what's called the emergent phase. Understanding the underlying physiology explains why standard fluid logic gets turned on its head. Heat injures capillary walls far beyond the visible burn. Damaged vessels become leaky and plasma proteins seep into surrounding tissue. The patient swells with edema while circulating blood volume actually drops. Some inundates. The body is puffy on the outside but running dry on the inside, sliding toward hypovolemic shock. Treatment is large volume IV crystalloid, typically lactated ringers, dosed by burn size and patient weight. The volume isn't fixed, it's titrated against patient response. The key bedside gauge is urine output, with a target of about 30 milliliters per hour in adults, reflecting adequate organ perfusion. This is where examiners test understanding. In heart failure, low urine output suggests fluid overload and calls for restriction or a diuretic. In the emergent burn phase, the logic flips. Low output means the capillary leak is outrunning replacement. The correct response is to increase the infusion rate, not slow it. Applying heart failure thinking to a burn is the classic error this scenario is built to catch. When a fresh major burn is paired with falling urine output, the physiology is hypovolemia from capillary leak, and restoring volume is always the fix. Question 6. A nurse is caring for a client who reports a possible myocardial infarction occurred about 2 weeks ago. Which of the following laboratory tests should the nurse expect the provider to use to confirm it? Your options are troponin T, B. Myoglobin, C. Creatine kinase MB, D. troponin E. Which would you go with? Lock it in before the reveal. The correct answer is A. Troponin T. A is correct because troponin T stays elevated the longest after cardiac injury, so it remains useful for confirming an infarction that happened as long as a couple of weeks earlier. The other markers return to baseline well before then. B is wrong because myoglobin rises and falls very early, returning to normal within about a day of injury. So long after the suspected event, it would read normal, making it useless for confirming an infarction this far in the past. C is wrong because creatine kinase MB returns to baseline quickly after myocardial damage. Because it clears so soon, it cannot detect an event that occurred well before testing, unlike troponin T with its much longer window. D is wrong because troponin I remains elevated for a shorter window than troponin T before declining to baseline. By this point it would likely have normalized, leaving troponin T as the only marker with a window long enough to confirm the event. When heart muscle dies, proteins spill into the bloodstream, and each one follows its own schedule. Understanding that schedule is what lets clinicians confirm a heart attack even days or weeks after it happened. Myoglobin appears first. We are within an hour or two. It sulfates but clears within a day. CKMB rises next and returns to baseline within a few days. Troponin T climbs early and stays elevated for 10 to 14 days, giving it the longest detection window of all three. The key exam skill is matching the marker to how much time has passed. Early markers like myoglobin are useful right now, but they vanish quickly. Only troponin T has the long tail needed to confirm an infarction from a week or two ago. The concepts most often confused are early detection and late confirmation. Myoglobin rises fast, making it tempting in any cardiac scenario, but speed is useless when the event is old. When the stem stresses time elapsed since chest pain, it is testing exactly this distinction. On any exam stem describing chest pain from days or weeks ago, the timeline is the clue. Short-lived markers will read negative even if real damage occurred. Troponin T is the one marker still standing after 2 weeks. Question 7. A nurse is caring for a client who has confusion and rapid deep breathing after an aspirin overdose. Which of the following acid-base imbalances should the nurse identify? Your options are A. Metabolic alkalosis, B. Respiratory acidosis, C. Metabolic acidosis, D. Uncompensated fluid excess. Don't overthink it. Which one feels right? The correct answer is C. Metabolic acidosis. C is correct because aspirin overdose ultimately produces metabolic acidosis with a low pH and a low bicarbonate level. The rapid, deep respirations the client shows represent the body attempting to compensate by exhaling more carbon dioxide. A is wrong because metabolic alkalosis involves a high bicarbonate from causes like vomiting or antacids. Salicylate toxicity drives bicarbonate down, so the alkalotic state is the reverse of what this client develops. B is wrong because respiratory acidosis reflects retained carbon dioxide from hypoventilation, yet this client is breathing rapidly and deeply. That fast breathing lowers carbon dioxide as compensation, which contradicts a carbon dioxide retaining disorder. D is wrong because uncompensated fluid excess is a volume problem, not the acid-base disturbance the question targets. Aspirin overdose disrupts hydrogen-ion balance and produces metabolic acidosis rather than a fluid imbalance. Salicylate poisoning is one of the classic causes of a mixed acid-base disturbance. To understand it, we need to see how the body's chemistry gets disrupted and how the body fights back. Salicylate uncouples the normal aerobic process inside the mitochondria, forcing cells into anaerobic metabolism. This floods the blood with organic acids like lactate, consuming bicarbonate, the body's main acid buffer, and driving the blood pH down. The result is a metabolic acidosis. Metabolic acidosis is identified by 3 hallmarks: a low blood pH, a low bicarbonate as the buffer is used up, and rising organic acids like lactate. The problem originates in the body's chemistry, not in the lungs. The brain's respiratory center detects the falling pH and drives faster, deeper breathing. Carbon dioxide is itself an acid in the blood, so exhaling more of it pushes pH back upward. Salicylate also stimulates the respiratory center directly, intensifying the effect. This is respiratory compensation, the lungs offsetting a metabolic problem. The key exam distinction is this: respiratory acidosis comes from retaining carbon dioxide due to slow or shallow breathing. In salicylate poisoning, it is the opposite. The patient breathes fast and deep to dump CO2. The rapid breathing is the rescue effort, not the disease. The underlying cause is always metabolic. Question 8. A nurse is reinforcing teaching with a client who has multiple sclerosis and a new prescription for baclofen. Which of the following statements indicates an understanding of the teaching? Your options are: oh, I can stop this drug suddenly. B, this medication treats my hand tremors. C, I should expect easy bruising. D, this will ease my muscle spasms. Got a guess? Lock it in. The correct answer is D. This will ease my muscle spasms. D is correct because baclofen is an antispasmodic that relieves the muscle spasticity common in multiple sclerosis. The client correctly identifies its purpose, and they should also know it can cause drowsiness and dizziness, which pose a safety concern. A is wrong because baclofen must never be stopped abruptly, because sudden discontinuation can cause withdrawal effects. Improvement in symptoms does not justify halting the drug on one's own, since the medication requires a gradual, provider-guided taper to discontinue safely. B is wrong because tremors in multiple sclerosis are treated with propranolol and clonazepam, not baclofen. This client has confused the spasticity benefit of baclofen with the tremor management that an entirely different drug combination is meant to provide here. C is wrong because easy bruising is an effect associated with prednisone, a corticosteroid, rather than baclofen. Attributing the skin finding to an antispasmodic reflects a mix-up with a different class of medication used during the course of the disease. In multiple sclerosis, the immune system attacks myelin, stripping away the insulation that nerve fibers need to carry signals cleanly. One result is spasticity, a state where muscles stay rigid and contract without the patient willing it. Normally, movement depends on a balance between excitatory and inhibitory signals. When demyelination damages the inhibitory pathways in the spinal cord, excitatory signals run unopposed, and muscles tighten and jerk uncontrollably. The stiffness is not weakness, it is the loss of dampening control. Baclofen restores some of that lost inhibition by acting on receptors in the spinal cord that respond to a calming neurotransmitter. This dampens the overactive reflex arcs driving the spasms, so muscles relax and involuntary contractions ease. 2 points examiners test closely. First, baclofen treats spasticity, muscle stiffness, and is not the drug for MS-related tremor, which requires different medications entirely. Second, baclofen must never be stopped abruptly. Sudden withdrawal can trigger rebound spasticity, high fevers, and seizures, so stopping always requires a slow, provider-guided taper. When you see MS paired with baclofen on an exam, think spasticity relief and mandatory tapering. Drowsiness and dizziness are expected side effects, and the drug must never simply be abandoned once the patient feels better. Question 9. A nurse is caring for a client who was burned in a house fire and now has hoarseness, a brassy cough, and drooling. Which of the following actions should the nurse take? Your options are: A. Document them as an expected response. B. Apply ice to the client's neck. C. Report these findings immediately. D. Encourage the client to drink fluids. Which one is it? Pause the video if you need more time. The correct answer is C. Report these findings immediately. C is correct because hoarseness, a brassy cough, and drooling indicate inhalation injury with impending airway obstruction. So the nurse reports these findings immediately. Prompt intervention is needed before swelling closes off the airway. A is wrong because these are warning signs of an airway emergency, not an expected response to a burn. Recording them as normal would delay the urgent action required and risk losing the airway as edema progresses. B is wrong because applying ice to the neck does not relieve airway swelling and waste critical time while the obstruction develops. The client needs immediate reporting and airway support, not a local measure that fails to address the danger. D is wrong because offering fluids to a client with drooling and impending airway compromise risks aspiration and does nothing to relieve the swelling. Oral intake is unsafe here, so encouraging drinking ignores the airway threat entirely. When someone survives a fire, the visible burns can distract from a quieter and faster threat: damage to the airway itself, inhaled heat, smoke, and toxic particles inflame the delicate mucous membranes lining the mouth and throat, triggering swelling that can seal the airway shut within hours. The lining of the upper airway has no room to spare. Even modest swelling dramatically narrows the passage, and crucially, the edema worsens over the first hours after exposure rather than improving, meaning the window to act is closing from the moment of injury. The body announces impending obstruction through 6 recognizable signs. A hoarse voice means the vocal cords are swelling. A brassy cough signals deep airway irritation. Drooling means swallowing has become painful. Stridor is high-pitched airflow through a narrowed passage. Singed nasal hairs and soot around the mouth confirm significant heat and smoke exposure. The cruel logic of airway edema is that it only grows harder to manage. A breathing tube that slides in easily now may be impossible to place an hour later once tissues have closed in. Early reporting and immediate airway securing beat watchful waiting every time. On any exam scenario involving fire or smoke exposure, especially indoors, separate skin findings from airway findings. Pain and blistering are managed in due course. Hoarseness, a brassy cough, and drooling forecast a closing airway and demand immediate action before the passage disappears. Question 10. A nurse is assessing a client who has acute pyelonephritis with fever and chills. Which of the following findings related to the kidney should the nurse expect? Your options are A. Costovertebral angle tenderness, B. Collar-colored urine with proteinuria, C. Painless bladder distension, D. An elevated antistreptolysin O titer. Take a second. Which answer would you pick? The correct answer is A. Costovertebral angle tenderness. A is correct because pyelonephritis inflames the kidney pelvis and produces flank pain with costovertebral angle tenderness. This finding, along with fever and chills, reflects the upper urinary tract infection the nurse expects when assessing the client. B is wrong because collar-colored urine with protein points to glomerulonephritis, an immunologic injury to the glomeruli. Pyelonephritis is a bacterial kidney infection marked by flank tenderness, so this finding belongs to a different renal disorder. C is wrong because painless bladder distension suggests urinary retention rather than the infection of the kidney pelvis. Pyelonephritis causes flank pain and tenderness, so a distended bladder without pain does not match the condition described. D is wrong because an elevated antistreptolysin O titer follows a streptococcal infection and supports glomerulonephritis. It is not a feature of pyelonephritis, so this lab finding points away from the bacterial kidney infection being assessed. Pyelonephritis is a bacterial infection of the kidney itself, not just the bladder. Understanding what makes it serious, how bacteria get there, and what signs point to it helps you distinguish it from other urinary tract conditions. Bacteria typically enter at the urethra, colonize the bladder, and then are seen through the ureters into the kidney. Once they reach the renal pelvis and deeper kidney tissue, the infection becomes an upper tract problem, and that location change is what makes it so much more serious. The hallmark triad of pyelonephritis is fever and chills, flank pain, and costovertebral angle tenderness. The costovertebral angle is where the lowest rib meets the spine, directly over the kidney. Sharp pain when that spot is struck tells you the kidney beneath is inflamed. Lower urinary tract infections speak the language of the bladder, burning on urination, urgency, and frequency. Pyelonephritis speaks a different language, systemic fever, chills, and flank tenderness. Reading which set of findings is present tells you exactly where the infection lives and how aggressively to treat it. Examiners love testing the distinction between pyelonephritis, glomerulonephritis, and lower UTI. Glomerulonephritis is an immune injury showing cola-colored urine and proteinuria after a strep infection. Not fever with flank tenderness. The key anchor, costovertebral angle tenderness paired with systemic fever and chills means bacterial infection of the kidney itself. Question 11. A nurse is caring for a client who is unresponsive after a motor vehicle crash and has a bleeding forehead laceration. Which of the following actions should the nurse take first? Your options are A. Apply pressure to the forehead wound. B. Insert an intravenous catheter. C. Keep the client's neck stabilized. D. Obtain a full set of vital signs. Before I reveal it, which one do you think is right? The correct answer is C. Keep the client's neck stabilized. C is correct because any client with a head injury may have a concurrent cervical spine injury. Keeping the neck stabilized first prevents movement that could cause permanent spinal cord damage, which is the greatest risk until injury is ruled out by imaging. A is wrong because controlling the forehead bleeding matters, yet scalp wounds bleed heavily without being immediately life-threatening. Protecting the spinal cord from a movement-induced injury outranks managing a laceration that simply is not the priority threat in this scenario. B is wrong because intravenous access supports fluids and medications, but establishing a line involves handling that could shift an unstable spine. Securing the neck must precede interventions that risk moving a potentially injured cervical column in this unresponsive client. D is wrong because vital signs guide ongoing care, though obtaining them does not address the danger of an unstable cervical spine. The priority is preventing cord damage before gathering data, which can follow once the client's neck is properly protected and stabilized. When a major head injury occurs, the neck is always at risk too. The cervical spine houses the spinal cord, the body's main signal cable connecting the brain to the arms, legs, trunk, and even the muscles that drive breathing. A fractured cervical vertebra may stay still on its own, but one careless movement can let it shift, crushing or severing the cord. Damage at that level can erase all movement and sensation below the neck or stop breathing entirely. Protection means immobilizing the neck in a neutral midline position. A rigid collar is applied. The head is kept in line with the body, and the patient is moved only by log rolling. Head, neck, and trunk as one unit, so nothing twists, flexes, or extends the spine. This is the key distinction examiners test: visible urgency versus lethal urgency. A bleeding scalp looks dramatic because the scalp is rich in vessels, but it is rarely immediately fatal. An unstable neck hides in plain sight, and cord damage caused by movement does not heal. In any high-impact trauma, especially an unresponsive patient, assume a cervical injury is present until imaging proves otherwise. Secure the neck first, then control the laceration. A scalp wound will heal, a severed cord will not. Question 12. A nurse is caring for a client who developed hypotension and tachycardia after receiving midazolam during a procedure. Which of the following medications should the nurse anticipate administering? Your options are A. Naloxone, B. Atropine, C. Dantrolene, D. Flumazenil. What's your answer? Commit to one before I continue. The correct answer is D. Flumazenil. D is correct because flumazenil reverses benzodiazepines such as midazolam, so the nurse anticipates giving it when the client reacts adversely to the sedative. This reversal agent counteracts the benzodiazepine's effects and helps restore the client's stability. A is wrong because naloxone reverses opioids, not benzodiazepines. Because midazolam is a benzodiazepine rather than an opioid, naloxone would not counteract its effects in this client and is the wrong reversal agent. B is wrong because atropine treats bradycardia by increasing heart rate and does not reverse benzodiazepine sedation. It addresses a slow pulse, so it would not resolve a reaction caused specifically by midazolam. C is wrong because dantrolene is the drug for malignant hypothermia, an entirely different emergency. It does nothing to reverse a benzodiazepine, so it has no role in managing this client's reaction to midazolam. When a benzodiazepine like midazolam pushes too far, depressing breathing or blood pressure, a targeted antidote is needed. Flumazenil is that antidote built specifically to reverse benzodiazepine effects at the receptor level. Benzodiazepines enhance the calming neurotransmitter GABA at its receptor, deepening sedation. Flumazenil fits the exact same binding site but does not activate it. By occupying that site competitively, it physically blocks the benzodiazepine and switches the effect off. Every reversal agent is key to one drug family. Naloxone reverses opioids, not benzodiazepines. Atropine addresses a dangerously slow heart rate. Dantrolene treats malignant hypothermia. Reaching for the wrong agent in an emergency wastes critical time. On an exam, when the STEM names a benzodiazepine and asks for a reversal agent, the answer is flumazenil. Every time. Read the drug that caused the problem, and the matching antidote follows directly. Question 13. A nurse is caring for a client who has a severe headache, neutral rigidity, and a positive Koenig's sign. Which of the following actions should the nurse take first? Your options are A. Establish intravenous access. B. Implement droplet precautions. C. Dim the lights in the room. D. Administer a prescribed antibiotic. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Implement droplet precautions. B is correct because these findings suggest bacterial meningitis, which is contagious and carries high mortality. Implementing droplet precautions first protects others from a spreadable, life-threatening infection, making it the priority before the other appropriate interventions are carried out. Is wrong because intravenous access is needed for fluids and medications, yet it does nothing to contain a transmissible pathogen. The immediate threat of spread to staff and other clients outranks securing a line at this particular moment. C is wrong because dimming lights eases photophobia and provides comfort, but comfort measures do not address contagion. This intervention can follow once the client is isolated and the infection is no longer free to spread to others nearby. D is wrong because antibiotics treat the client and are given soon, though they take time to render secretions non-infectious. Until then, the surrounding people remain exposed. So isolation must come before drug administration in this situation here. Bacterial meningitis is an infection of the meninges, the protective membranes surrounding the brain and spinal cord. Certain organisms, especially meningococcus, spread through respiratory droplets and can kill a healthy adult within hours, making every suspected case both a medical and an infection control emergency. The classic triad is severe headache, stiff neck, and fever. 2 bedside findings reinforce the diagnosis. Koenig's sign, where straightening the knee with the hip flexed causes pain, and Brudzinski's sign, where bending the neck triggers involuntary leg flexion. Sensitivity to light often accompanies these signs. Meningococcal meningitis travels on droplets, so droplet precautions apply: a surgical mask and a private room. Airborne precautions: requiring a fitted respirator and a negative pressure room, are reserved for tuberculosis and measles. Contact precautions cover organisms spread by touch. On exams, the key nuance is sequencing. Droplet isolation takes priority over everything else because it can be enacted immediately and protects everyone in the room. Antibiotics are urgent and follow closely, but secretions stay infectious for roughly a day after treatment begins. Dimming lights helps photophobia but does nothing to prevent spread. When an exam question lists the meningitis triad or a positive Koenig's or Brudzinski's sign and asks for the first action, it is testing whether you rank containment above comfort and above starting other interventions. A stiff neck with fever should immediately trigger thoughts of droplet isolation. Question 14. A nurse is assessing a client who has been diagnosed with systemic lupus erythematosus. Which of the following findings should the nurse expect to observe in this client? Your options are A. A butterfly-shaped rash across the cheeks. B. Weight gain and increased appetite. C. A systolic heart murmur. D. Petechiae across the trunk. Which would you go with? Lock it in before the reveal. The correct answer is A. A butterfly-shaped rash across the cheeks. A is correct because the erythematous butterfly rash across the nose and cheeks is a hallmark of systemic lupus erythematosus, accompanied by fatigue, alopecia, and weight loss as the autoimmune inflammation affects multiple body systems. B is wrong because lupus typically causes anorexia and weight loss, not weight gain with increased appetite. Expecting the client to eat more and gain weight runs counter to the systemic inflammation and poor appetite that mark the disease. C is wrong because the cardiac involvement in lupus produces pericarditis with a friction rub rather than a systolic murmur. Listening for a murmur looks for the wrong cardiac sign, since the inflammatory process affects the pericardium. D is wrong because petechiae suggest a platelet or bleeding problem, while lupus is characterized by the butterfly rash. Although low blood counts can occur, scattered petechiae are not the expected skin finding that distinguishes this disorder. Systemic lupus erythematosus is a chronic autoimmune disease where the immune system loses its ability to distinguish self from non-self. Instead of defending the body, it turns against it, producing autoantibodies that deposit in tissues and trigger inflammation across multiple organ systems. The most recognizable sign of lupus is the malar rash, a reddened patch spread across both cheeks and the bridge of the nose in a butterfly shape. It characteristically worsens with sun exposure, reflecting the photosensitivity that runs throughout this disease. Because lupus is systemic, inflammation doesn't stay in one place. It can strike the skin and joints, kidneys, the membranes around the heart and lungs, blood cells, and the nervous system, flaring and quieting unpredictably over years. Examiners test whether you can separate true lupus features from lookalikes. Lupus brings the butterfly rash, not petechia, weight loss, not weight gain, and pericarditis with a friction rub, not a plain systolic murmur. Photosensitivity alongside multi-system involvement seals the picture. Question 15. A nurse is preparing a client for a thoracentesis at the bedside. Which of the following positions should the nurse help the client assume for the procedure? Your options are A. Supine with the bed flat. B. Lying on the affected side. C. Sitting upright, leaning over a table. D. Prone with arms at the sides. Don't overthink it. Which one feels right? The correct answer is C. Sitting upright, leaning over a table. C is correct because sitting upright and leaning forward over a bedside table widens the intercostal spaces and lets fluid settle at the lung base. This gives the provider the safest access to the pleural space for needle insertion. A is wrong because lying flat allows pleural fluid to spread along the back, rather than pooling where the needle can reach it. The supine position also narrows the rib spaces, making safe entry into the pleural space harder for the provider. B is wrong because resting on the affected side compresses the very lung the provider needs to access and does not open the intercostal spaces. Fluid would not collect at a reachable site, defeating the goal of drainage. D is wrong because a prone position offers no access to the lateral chest wall where the needle enters and does not spread the ribs. The upright leaning posture is what positions fluid and tissue correctly for the tap. Thoracentesis drains fluid or air from the pleural space, the thin gap between the lung and chest wall. Understanding why position matters starts with understanding what that space is and why it fails. The pleural space normally holds just a slick of lubricating fluid. When infection, heart failure, cancer, or injury fills it with excess fluid, that fluid presses on the lung and prevents it from expanding fully, causing shortness of breath. Sitting upright and leaning forward over a bedside table accomplishes three things at once. It spreads the ribs apart to widen the spaces for the needle, lets gravity pull fluid down to pool at the lung base, and keeps the needle path away from the lung itself. The alternatives each introduce a problem. Lying flat spreads fluid along the back and narrows rib spaces. Lying on the affected side compresses the very lung being treated. Face down offers no access. Only the seated forward-leaning posture both opens the access and gathers the fluid where it can be reached. When an exam question describes preparation for a thoracentesis or a bedside pleural tap, the answer is always the upright, forward-leaning posture. Contrast this with lumbar puncture, which uses a curled sideline position to open the vertebral spaces instead. Question 16. A nurse is planning care for an older adult client who has severe anemia and reports dizziness when standing. Which of the following actions should the nurse include to address the priority concern? Your options are A. Assist the client with ambulation. B. Weigh the client weekly. C. Restrict the client's oral fluids. D. Encourage rapid position changes. Got a guess? Lock it in. The correct answer is A. Assist the client with ambulation. A is correct because severe anemia with orthostatic dizziness threatens client safety. So assisting with ambulation, monitoring oxygen saturation, and scheduling rest periods protects against falls while the underlying oxygen deficit is treated. B is wrong because clients with anemia are weighed daily, not weekly, to detect fluid changes and complications such as developing heart failure. A weekly schedule would miss early shifts and does not address the immediate fall hazard from dizziness. C is wrong because limiting fluids does not treat anemia and could worsen orthostatic symptoms by reducing circulating volume. Adequate hydration supports blood pressure on standing, so fluid restriction works against the client's safety here. D is wrong because encouraging fast position changes invites a sudden drop in cerebral perfusion and a fall in this already dizzy client. Teaching slow, gradual movements is what protects against syncope, making rapid changes harmful advice. When a patient with severe anemia stands up and feels dizzy, two problems are colliding at once. Understanding why helps you choose the right nursing action immediately. Anemia reduces the blood's ability to carry oxygen throughout the body. When the patient stands, gravity briefly pulls blood toward the legs, causing a momentary drop in blood pressure, a pattern called orthostatic hypotension. In an already oxygen-starved patient, that brief dip can tip into lightheadedness, blurred vision, or fainting. The brain is especially sensitive to drops in oxygen supply. When both low hemoglobin and a positional blood pressure dip occur together, The brain can be left under-perfused long enough to cause a fall from standing height, which can fracture a hip or cause a head injury. Because a fall can happen in the next minute, safety measures must come before treating the anemia itself. Assisting the patient when walking, teaching slow and stage position changes, and monitoring oxygen saturation are the actions that prevent immediate harm while the underlying anemia is corrected over time. On an exam, when you see anemia paired with dizziness on standing, the priority is fall prevention, not the anemia treatment. Assisting with ambulation and slowing position changes guard against injury now. The distinction is immediate safety versus long-term care. Question 17. A nurse is reviewing the record of a client who received 3 tap water enemas and now has a low sodium and low potassium level. Which of the following does the nurse identify as the cause? Your options are A. Isotonic IV fluid administration, B. Routine antibiotic therapy, C. A high sodium meal plan, D. Tap water enemas diluting electrolytes. Which one is it? Pause the video if you need more time. The correct answer is D. Tap water enemas diluting electrolytes. D is correct because tap water is hypertonic and the GI losses from enemas are isotonic, so repeated tap water enemas dilute the blood and flush out electrolytes, producing the low sodium and potassium described. A is wrong because isotonic IV fluids match the body's tonicity and would not dilute the blood or cause this drop. Because they do not lower electrolytes, they cannot explain the low sodium and potassium values. B is wrong because routine antibiotics do not characteristically deplete sodium and potassium through this mechanism. The imbalance here arises from the enemas, not from antibiotic therapy, which targets infection instead. C is wrong because a high sodium meal plan would tend to raise sodium rather than lower it. This intake works against the observed hyponatremia, so it cannot be the source of the depleted electrolytes. To understand why repeated tap water enemas drop sodium and potassium, we need to understand tonicity, how the concentration of a fluid compares to the body's own blood and cells. Tap water is hypertonic, meaning it contains far fewer dissolved particles than blood. Isotonic fluids, like normal saline, match blood concentration and create no driving force for dilution. The difference is everything. Because the colon wall readily absorbs water, osmosis drives tap water from the lumen into the saltier bloodstream. Water always moves toward the higher concentration and the body cannot override this force. As hypertonic water floods the blood, it dilutes sodium, a dilutional hyponatremia. Repeated flushing also carries potassium out of the gut. Both electrolytes fall, but for slightly different reasons. One is diluted, the other is washed away. On an exam, repeated tap water enemas followed by low sodium and low potassium point to one cause: hypertonic absorption and dilution. Isotonic fluids, antibiotics, or diet changes cannot produce this picture. The tonicity of tap water is the whole story. Question 18. A nurse is assisting with the care of a client who is in ventricular fibrillation. Which of the following interventions should the nurse anticipate? Your options are A. Synchronized cardioversion to the R wave, B. Defibrillation with an unsynchronized shock, C. Administration of intravenous atropine, D. Insertion of a permanent pacemaker. Take a second. Which answer would you pick? The correct answer is B. Defibrillation with an unsynchronized shock. B is correct because ventricular fibrillation is a pulseless, chaotic rhythm treated with immediate unsynchronized defibrillation. The countershock stops all electrical activity, so the sinus node can resume a perfusing rhythm, the appropriate emergency response. A is wrong because synchronized cardioversion times the shock to the R wave, and is used for organized rhythms like atrial fibrillation or VT with a pulse. Ventricular fibrillation has no organized R wave to synchronize with, so unsynchronized defibrillation is required. C is wrong because atropine is the drug for symptomatic bradycardia, not for a lethal ventricular rhythm, given it would waste critical time in ventricular fibrillation, which demands an immediate defibrillating shock rather than a heart rate medication. D is wrong because a permanent pacemaker addresses chronic brady dysrhythmias and conduction failures, not an acute pulseless arrest. The client in ventricular fibrillation needs immediate defibrillation, an emergency measure entirely different from elective pacemaker placement. When the heart falls into ventricular fibrillation, it quivers chaotically. The ventricles never coordinate a real beat. No blood is pumped, and the patient has no pulse. An electrical shock is the reset button that stops all activity at once, giving the heart's natural pacemaker a chance to resume an organized rhythm. Ventricular fibrillation produces a chaotic, formless waveform with no R wave. There is simply nothing for a synchronized machine to detect. An organized rhythm, by contrast, has a clear R wave that a synchronized cardioverter can time its shock to. The mode you choose depends entirely on the rhythm. Ventricular fibrillation and pulseless ventricular tachycardia require an unsynchronized shock fired immediately. Atrial fibrillation or ventricular tachycardia that still produces a pulse call for synchronized cardioversion, where the machine waits for the R wave before delivering energy. If a defibrillator is mistakenly left in synchronized mode during ventricular fibrillation, it will wait for an R wave that never comes and will never discharge. That delay is fatal. Every second without circulation destroys brain and heart tissue, which is why early, unsynchronized defibrillation sits at the core of resuscitation. When an exam describes a chaotic waveform with no pulse, the answer is always immediate. Unsynchronized defibrillation. Pulselessness plus disorganized rhythm means defibrillate now, and Bas never reach for synchronized mode or a rate-controlling drug first. Question 19. A nurse is caring for a client who is recovering from a total knee arthroplasty. Which of the following actions should the nurse take to support recovery of the operative joint? Your options are: A. Position a pillow behind the knee. B. Apply a heating pad to the joint. C. Place a pillow under the lower calf. D. Keep the heels resting on the bed. Before I reveal it, which one do you think is right? The correct answer is C. Place a pillow under the lower calf. C is correct because placing a pillow under the lower calf keeps the knee in slight extension and helps prevent flexion contractures. This positioning, combined with keeping the heels off the bed, protects range of motion after a knee replacement procedure. A is wrong because a pillow behind the knee holds the joint in flexion and promotes a flexion contracture. The goal is to keep the knee extended, so the support belongs under the calf rather than directly behind the knee itself. B is wrong because ice, not heat, is applied after knee arthroplasty to reduce swelling and pain. A heating pad would increase circulation and edema at the operative site, which works against the cooling that the healing joint actually requires during recovery. D is wrong because the heel should be kept off the bed to prevent pressure injury and to support proper alignment. Letting the heels rest on the mattress leaves them vulnerable to skin breakdown during recovery, so this position is avoided after the surgery. After a total knee arthroplasty, how the leg is positioned during recovery directly shapes the patient's long-term outcome. The joint will stiffen in whatever position it spends the most time, so positioning is a deliberate clinical choice, not an afterthought. When a replaced knee rests in flexion for long periods, scar tissue and tight structures form around it in that bend shape. This creates a flexion contracture, a fixed bend that prevents full leg straightening and undermines the entire benefit of the replacement. The critical distinction is where the pillow goes. A pillow placed behind the knee holds the joint in flexion, encouraging the very contracture the plan aims to prevent. A pillow under the lower calf and ankle supports the leg, while letting the knee fall into extension and keeps the heel floating free of the mattress. 3 principles guide early post-operative care. Support goes under the calf to maintain extension. The heel stays off the bed to prevent pressure injury, and ice rather than heat is applied over the joint to control swelling and pain in the early recovery days. When an exam question involves positioning after knee replacement, the answer turns on where the support goes. Under the calf promotes the extension patients need to walk. Behind the knee steals it. Keep the heel off the bed and choose cold over heat to complete the picture. Question 20. A nurse is monitoring a client during the first few minutes of a transfusion when the client reports chills and low back pain and appears flushed. Which of the following actions should the nurse take first? Your options are: A. Stop the transfusion. B. Slow the transfusion rate. C. Administer an antipyretic. D. Notify the provider. What's your answer? Commit to one before I continue. The correct answer is A. Stop the transfusion. A is correct because chills with low back pain early in a transfusion suggest an acute hemolytic reaction from incompatibility. Stopping the infusion immediately halts the entry of more incompatible blood, which is the priority before any other intervention. B is wrong because merely slowing the rate keeps incompatible blood flowing into the client and allows the hemolytic process to progress. The reaction demands a complete halt, not a reduction, to limit the volume of mismatched cells delivered. C is wrong because an antipyretic treats fever from a febrile reaction, but does nothing to address the life-threatening incompatibility unfolding here. Stopping the blood comes before any medication, so the trigger is removed first. D is wrong because the provider does need to be informed. Yet, contacting them before halting the infusion wastes critical time while incompatible blood continues to enter the client. The nurse stops the transfusion, then notifies. When incompatible blood enters a patient's bloodstream, the immune system launches an immediate and potentially fatal counterattack. Understanding why this happens and what to do first is the core of this concept. Every person carries ready-made antibodies against blood types they don't have. The moment incompatible donor cells enter the circulation, those antibodies bind and rupture the cells instantly, releasing debris that clogs the kidneys and triggers a cascade of shock and uncontrolled clotting. The warning signs appear early, often within the first minutes. Chills, fever, and flushing strike first. Low back or flank pain reflects kidney stress, and dark urine follows as broken down hemoglobin spills into it. These findings, arriving right at the start of a transfusion, are the signature of a hemolytic reaction. The single most critical step is stopping the transfusion immediately. Every additional drop of incompatible blood worsens the reaction. Only after the blood is halted do you run normal saline through fresh tubing to protect the kidneys. Then notify the provider. Stopping comes before everything else. The key distinction to hold is this: a hemolytic reaction brings back pain, chills, and shock. It turns deadly fastest and demands stopping the blood at once. A mild allergic reaction produces only hives and itching and is managed with an antihistamine. Both begin by halting the transfusion, but the hemolytic picture is the true emergency. Question 21. A nurse is caring for a client during surgery who develops early signs of malignant hypothermia. Which of the following actions should the nurse anticipate? Your options are: A. Continuing surgery while observing the client. B. Administering fordontrolene and stopping surgery. C. Withholding oxygen until the temperature rises. D. Applying warming blankets to the client. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B, administering IV dantrolene and stopping surgery. B is correct because for malignant hypothermia, the team administers IV dantrolene, terminates the surgery, gives high-flow oxygen, and cools the client with iced fluids and a cooling blanket to halt the crisis. A is wrong because continuing the surgery allows this life-threatening reaction to keep worsening. The correct response is to terminate the procedure immediately. So proceeding while merely observing the client would place that client in serious danger. C is wrong because withholding oxygen is dangerous because the client needs high-flow oxygen during this crisis. Waiting for the temperature to climb ignores that an extremely high temperature is a late sign, not a trigger to act. D is wrong because warming blankets would raise body temperature and intensify the hypothermia. Management calls for cooling with iced fluids and a cooling blanket, so adding warmth directly opposes the needed treatment. Malignant hypothermia is a rare, inherited, life-threatening reaction to certain anesthetic agents, primarily inhaled anesthetics and succinylcholine. Understanding why it happens, how to recognize it early, and exactly how to treat it can be the difference between a survivable crisis and a fatal one. The root cause is a genetic defect in the ryanodine receptor, the calcium channel inside skeletal muscle cells. Normally, calcium is released in a controlled pulse to trigger contraction, then pumped back so the muscle relaxes. Triggering drugs force this channel open uncontrollably, locking muscles in continuous contraction and generating massive heat, carbon dioxide, and lactic acid. The crisis announces itself metabolically before it announces itself thermally. The first signs are a sharp rise in exhaled carbon dioxide, an unexplained fast heart rate, rapid breathing, and jaw rigidity. The dramatic temperature spike that names the disease is actually a late development, arriving well after the metabolic storm is already raging. Treatment must be immediate and simultaneous. Stop the inhaled anesthetic and halt the surgery. Give intravenous dantrolene, the only drug that calms the crisis by blocking the runaway calcium channel. Provide high-flow oxygen and cool the patient aggressively with ice fluids and cooling blankets. Never warming blankets, which push in exactly the wrong direction. The exam trap is waiting for the temperature spike before acting, but heat is a late marker, not a starting gun. When you see rising carbon dioxide, tachycardia, and rigidity during anesthesia, recognize malignant hypothermia immediately. Stop the triggers, and give dantrolene. Acting on early metabolic signs, not late thermal ones, is what saves the patient. Question 22. A nurse is caring for a client who has neuropathic cancer pain and is starting gabapentin. Which of the following adverse effects should the nurse instruct the client to expect? Your options are constipation, B, urinary retention, C, insomnia, D, dizziness. Which would you go with? Lock it in before the reveal. The correct answer is D, dizziness. D is correct because gabapentin commonly causes dizziness and drowsiness, so the client is told to avoid driving until the effects are known. Anticipating dizziness helps the client stay safe, while the anticonvulsant controls neuropathic pain. E is wrong because constipation is a hallmark adverse effect of opioids rather than gabapentin. Attributing it to this anticonvulsant misassigns an opioid problem and overlooks the dizziness and sedation that actually accompany gabapentin therapy. B is wrong because urinary retention is associated with opioids and anticholinergic drugs, not with gabapentin. Expecting it here points to the wrong medication class and misses the dizziness that the client genuinely needs to anticipate. C is wrong because gabapentin produces sedation, so insomnia is the opposite of its usual effect. Telling the client to expect trouble sleeping contradicts the drowsiness the drug causes and could leave the client unprepared for the real effect. Gabapentin was originally developed as an anti-seizure medication, but it has become a cornerstone treatment for neuropathic pain, the burning, shooting pain caused by damaged or irritated nerves. Cancer pressing on nerves is a classic source of exactly this kind of pain. Gabapentin works by binding to calcium channels in nerve cells, reducing the release of pain-transmitting signals. Damaged nerves fire on their own without any new injury to trigger them, and gabapentin quiets that abnormal firing at its source. Because gabapentin dampens the entire nervous system, its hallmark side effects are dizziness and drowsiness, not bowel or bladder problems. Constipation and urinary retention are signatures of opioids, not gabapentin. Knowing which effect belongs to which drug is exactly what examiners test. Patient teaching focuses on safety during the early days of therapy, when dizziness and unsteadiness are most pronounced. Patients should avoid driving or operating machinery, rise slowly to prevent falls, and understand that doses are raised gradually to help the body adjust. Question 23. A nurse is caring for a client receiving total parenteral nutrition through a central line. Which of the following actions should the nurse take? Your options are A. Infuse antibiotics through the same line. B. Increase the rate to catch up. C. Check capillary blood glucose regularly. D. Change the tubing only once weekly. Don't overthink it. Which one feels right? The correct answer is C. Check capillary blood glucose regularly. C is correct because the hypertonic dextrose in parenteral nutrition raises blood glucose, so regular capillary glucose checks guide supplemental insulin. Monitoring catches the hyperglycemia this therapy commonly produces and protects the client from swings in serum glucose. A is wrong because the parenteral nutrition line is dedicated to that solution alone. Running antibiotics through it invites incompatibility and infection. Medications and other fluids belong in a separate access, never the line carrying this nutrient-rich solution. B is wrong because speeding the infusion to make up a deficit causes dangerous shifts in blood glucose and fluid volume. An infusion pump should maintain a steady rate, so deliberately catching up does the opposite of safe practice. D is wrong because the high glucose content feeds bacteria, so tubing and bag are changed daily rather than left for several days. Stretching the interval this far raises the infection risk the shorter schedule is designed to prevent. Total parenteral nutrition delivers complete nutrition directly into the bloodstream through a central line, bypassing the gut entirely. It's reserved for patients whose digestive tract cannot be used, and its sugar-heavy formula creates both its value and its main hazards. The formula is hypertonic, far too concentrated for a small peripheral vein, which it would irritate and damage. A central line is required because large central veins can handle the rich, concentrated solution safely. Safe management rests on 4 rules. Capillary glucose is checked regularly because the high dextrose load reliably drives blood sugar up. The line is kept dedicated to TPN alone to prevent incompatibility and infection. The infusion runs at a steady rate, never sped up, and tubing is changed daily because the sugary solution breeds bacteria. Each rule targets a specific hazard. Sharing the line risks contamination. Speeding the rate causes hazardous glucose and fluid swings. Stretching tubing changes lets bacteria flourish. On an exam, when you see TPN through a central line, the central safeguard is regular capillary glucose monitoring with insulin adjusted as needed. Remember, parenteral nutrition demands a dedicated line, a steady rate, daily tubing changes, and above all, regular glucose monitoring. That consistent monitoring is what keeps this life-sustaining therapy from causing the very harm it is meant to prevent. Question 24. A nurse is collecting data from a client who has a diagnosis of Meniere's disease. Which of the following findings should the nurse expect to identify in this client? Your options are A. Bulging red bilateral eardrums, B. Unilateral sensorineural hearing loss, C. Purulent drainage in the ear canal, D. Loss of the gag reflex. Got a guess? Lock it in. The correct answer is B. Unilateral sensorineural hearing loss. B is correct because Meniere's disease is marked by episodic vertigo, tinnitus, and fluctuating sensorineural hearing loss that typically affects one ear. Unilateral sensorineural loss reflects the inner ear involvement that defines this disorder and distinguishes it from middle ear problems. A is wrong because bulging red eardrums indicate a middle ear problem such as otitis media, not an inner ear disorder. Meniere's disease arises in the cochlear and semicircular canals, beyond the eardrum that this particular finding actually describes during examination of the ear. C is wrong because purulent drainage in the canal suggests an external or middle ear infection. Meniere's disease does not produce canal discharge because its pathology lies within the fluid-filled inner ear rather than the outer pathway that this drainage would involve. D is wrong because loss of the gag reflex points to cranial nerve involvement affecting swallowing, not to inner ear disease. Meniere's symptoms center on hearing and balance, which makes an absent gag reflex unrelated to the condition this client actually has. Meniere's disease is a disorder of the inner ear, the structure responsible for both hearing and balance. It arises from excess fluid in the labyrinth, the maze of fluid-filled chambers that sense sound and head movement. Inside the labyrinth, delicate hair cells translate sound and motion into nerve signals. When endolymph fluid builds up beyond what the chambers can handle, pressure disrupts these hair cells, simultaneously impairing both hearing and balance. Attacks produce three hallmark symptoms: severe spinning vertigo, a roaring tinnitus in the affected ear, and a fluctuating sensorineural hearing loss. Crucially, this hearing loss involves one ear and comes from the inner ear and nerve, not a blockage. The key distinction examiners test is separating inner ear problems from middle and outer ear problems. Meniere's causes a one-sided sensorineural loss, while otitis media inflames the middle ear, causing a conductive loss with a bulging drum. When you see vertigo with tinnitus and a fluctuating one-sided hearing loss, think Meniere's, a problem rooted in the fluid balance of the inner ear, not the eardrum or ear canal. Question 25. A nurse is caring for a client who has diabetic ketoacidosis. Which of the following findings should the nurse expect with the associated acid-base imbalance? Your options are A. Cosmal respirations, B. Numbness and tingling with tetany, C. Tinnitus and finger numbness, D. Tachycardia from anxiety only. Which one is it? Pause the video if you need more time. The correct answer is A. Cosmal respirations. A is correct because diabetic ketoacidosis causes metabolic acidosis with a low bicarbonate, and the client develops Kussmaul respirations. These rapid deep breaths are the lungs compensating by blowing off carbon dioxide to raise the falling pH. B is wrong because numbness, tingling, and tetany are features of metabolic alkalosis, not metabolic acidosis. These signs reflect a high bicarbonate state, so they do not match the acidosis driven by ketoacidosis. C is wrong because tinnitus and finger numbness point to respiratory alkalosis from hyperventilation. While salicylate toxicity can begin that way, the ketoacidosis here produces metabolic acidosis and it's deep Kussmaul breathing. D is wrong because tachycardia attributed to anxiety alone fits respiratory alkalosis rather than the acidosis of ketoacidosis. Choosing it overlooks the deep, compensatory small respirations that truly distinguish the metabolic acidosis developing in this client. Diabetic ketoacidosis is a life-threatening complication of type 1 diabetes in which a near-total absence of insulin drives the body into a dangerous acid state. Understanding the chain of events helps you recognize its hallmark signs. Without insulin, cells cannot use glucose, so blood sugar climbs and the body burns fat instead. Fat metabolism floods the bloodstream with ketone acids, consuming bicarbonate buffers and dropping blood pH into a metabolic acidosis. Sensing the dangerously low pH, the respiratory center triggers small respirations, deep, rapid, forceful breaths that blow off carbon dioxide. Since CO2 acts as an acid in blood, exhaling more of it nudges the pH back upward. A fruity acetone odor on the breath signals ketones being exhaled at the same time. The key distinction examiner's test is separating acidosis signs from alkalosis signs. Small respirations and fruity breath belong to metabolic acidosis. Tetany, tingling, and tinnitus belong to alkalotic states with high bicarbonate. They do not appear in DKA. When a question names diabetic ketoacidosis alongside deep rapid breathing and a fruity breath odor, recognize that pattern as metabolic acidosis with respiratory compensation. Chelate, not an alkalosis. That distinction is the core of what examiners are testing. Question 26. A nurse is reinforcing teaching with a client who has a new prescription for metoprolol after a myocardial infarction. Which of the following statements by the client indicates an understanding of the teaching? Your options are: A. I will expect ringing in my ears. B. I will check my prothrombin time regularly. C. I will take this only for pain. D. Or will report a low pulse rate. Take a second. Which answer would you pick? The correct answer is D. I will report a low pulse rate. D is correct because metoprolol slows the heart rate, so the client should check the pulse and notify the provider when it falls below the parameter set by the provider. This precaution guards against excessive bradycardia from the beta blocker. A is wrong because ringing in the ears, or tinnitus, is a sign of aspirin toxicity, not an effect of metoprolol. Expecting this symptom from the beta blocker confuses two different cardiac medications and their distinct adverse effects. B is wrong because prothrombin time monitoring applies to warfarin, an anticoagulant, because metoprolol does not affect clotting. The relevant safety check for this beta blocker is the pulse rate, making the clotting time statement incorrect here. C is wrong because metoprolol is taken on a scheduled basis to lower heart rate and blood pressure and reduce infarct size, not only for pain. Using it solely during pain misses its ongoing cardioprotective purpose after a heart attack. After a myocardial infarction, the heart is injured and vulnerable. Metoprolol, a beta blocker, is prescribed to protect it by reducing the workload the damaged muscle must handle. Adrenaline normally binds to beta receptors on the heart, driving it to beat faster and harder. Metoprolol occupies those receptors, shielding them from adrenaline and calming the heart's rate and force. Together, these three effects, slowing the heart rate, easing the force of each beat, and lowering blood pressure, reduce how much oxygen the recovering heart must consume, which is exactly what the damaged muscle needs. Different cardiac drugs require different monitoring habits. Metoprolol means watching for bradycardia by checking the pulse. Warfarin means monitoring clotting with a prothrombin time. Ringing in the ears signals aspirin toxicity, or not a beta blocker side effect. The exam signal is simple. When the drug is a beta blocker like metoprolol, the patient's safety habit is checking the pulse and reporting a heart rate that falls too low, typically below 60 beats per minute. Question 27. A nurse is triaging a client who has a traumatic limb amputation. Which of the following triage levels should the nurse assign to this client? Your options are non-urgent, B, emergent, C, less urgent, D, urgent. Before I reveal it, which one do you think is right? The correct answer is B, emergent. B is correct because a traumatic amputation is emergent, a problem needing time-sensitive treatment because it has the potential to become life-threatening or limb-threatening. Rapid intervention protects both the client's survival and the affected extremity. A is wrong because the non-urgent level covers simple problems like a rash that need only minor management. Assigning a traumatic amputation here would gravely underestimate a limb-threatening injury that requires prompt care. C is wrong because less urgent describes conditions such as a laceration that can safely wait. An amputation cannot wait without risking the limb and life. So this category fails to match its time-sensitive nature. D is wrong because the urgent level fits problems that need treatment but are not life-threatening, like a fracture. A traumatic amputation carries limb-threatening potential beyond this tier, placing it one level higher. Triage is the process of sorting patients by severity so the sickest receive care first. When resources are limited, a structured priority system decides who gets treated and in what order. The levels run from emergent, where delay can be fatal or cost a limb, down through urgent, less urgent, and non-urgent, where a stable patient can wait without coming to lasting harm. A traumatic amputation is the classic emergent case. The severed limb can bleed heavily enough to threaten life, and every minute without intervention increases that risk, which is exactly what the emergent category is designed for. Sorting by severity, not arrival order, saves the most lives by matching the most pressing needs to the first available care. It directs staff and equipment where delay does the most harm while letting stable patients wait safely. On an exam, when a scenario describes a limb or life-threatening injury like a traumatic amputation, the answer is always emergent, the top priority. Lower tiers are reserved for stable conditions that can tolerate a wait. Question 28. A nurse is caring for a client who has COPD and requires a precise concentration of oxygen. Which of the following delivery devices should the nurse anticipate using? Your options are A, simple face mask, B, nasal cannula, C, venturi mask, D, partial rebreather mask. What's your answer? Commit to one before I continue. The correct answer is C, venturi mask. C is correct because the venturi mask delivers the most precise oxygen concentration and is preferred for chronic lung disease. Exact control matters in COPD, where excessive oxygen can blunt the hypoxic respiratory drive these clients depend on. A is wrong because a simple face mask is a low-flow device delivering a variable, approximate concentration that shifts with the client's breathing pattern. It cannot guarantee the exact percentage that careful oxygen control in COPD requires. B is wrong because a nasal cannula provides only an estimated oxygen percentage that changes with respiratory rate and depth. For a client needing an exact concentration, this low-flow option lacks the precision a venturi system delivers. D is wrong because a partial rebreather supplies higher oxygen but still in an imprecise, breathing-dependent range. The clinical need here is exactness, which the venturi mask alone among these choices is designed to provide reliably. Not all oxygen delivery devices are equal. The key difference is whether they deliver a fixed, exact concentration or a variable, approximate one. That distinction becomes critical in certain patients where too much oxygen can actually cause harm. The venturi mask works as a high-flow system with calibrated adapters that pull in room air at a fixed ratio to the oxygen supply, producing a precise concentration that stays constant regardless of how the patient breathes. Low-flow devices like the nasal cannula, simple face mask, and partial rebreathers simply add oxygen to whatever air the patient inhales. Patients with long-standing COPD may have adapted to use a low oxygen level as their primary stimulus to breathe. Flooding them with excess oxygen can blunt that drive, allowing carbon dioxide to climb to dangerous levels. The goal is precise delivery, enough to relieve hypoxia, but no more. The Venturi mask is the only device that guarantees an exact set percentage of oxygen. The nasal cannula, simple face mask, and partial rebreather all deliver approximate, shifting amounts that vary with the rate and depth of each breath. Wax years, they cannot be pinned to a precise figure. On an exam, when a question stresses precision or an exact oxygen percentage, especially in a COPD patient, the answer is the Venturi mask. It is the one device built to guarantee a set concentration breath after breath. Question 29. A nurse is assessing a client who collapsed outdoors during extreme heat and suspects heat stroke. Which of the following findings should the nurse expect? Your options are A. Lack of perspiration with altered mental status. B. Profuse sweating with a normal temperature. C. Low heart rate with increased urine output. D. Cool moist skin with hypertension. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Lack of perspiration with altered mental status. A is correct because heat stroke produces a lack of perspiration, an elevated temperature, and alterations in mental status. The failure to sweat distinguishes this medical emergency, which requires immediate treatment to prevent death. B is wrong because profuse sweating with a normal temperature describes heat exhaustion rather than heat stroke. Heat stroke is marked by the loss of the ability to perspire and a dangerously high temperature, not preserved sweating. C is wrong because heat stroke raises the heart rate and decreases urine output, so a low pulse with increased output contradicts the expected picture. These findings would point away from the failing thermoregulation of heat stroke. D is wrong because cool moist skin with hypertension opposes heat stroke, which causes hot dry skin and low blood pressure. The hallmark is absent perspiration and hypertension, the reverse of these described findings. Heat stroke is a true medical emergency, not just feeling overheated, but a complete breakdown of the body's ability to regulate its own temperature. Understanding why it happens and what it looks like starts with the limits of thermoregulation itself. Normally the body sheds heat by sweating and routing blood to the skin, but extreme heat, hard exertion, dehydration, and high humidity can push past what those defenses can handle. And once the system is overwhelmed, perspiration stops entirely, just when the body needs it most. The key distinction examiners test is separating heat stroke from heat exhaustion. In heat exhaustion, the cooling system still works. The patient sweats heavily, temperature stays near normal, and the mind stays clear. Heat stroke inverts that picture completely. The three defining findings of heat stroke are a dangerously high core temperature, hot and dry skin from absent sweating, and altered mental status, ranging from confusion and agitation all the way to seizures and collapse. This triad signals that the brain and organs are already under heat damage. When a patient collapses in extreme heat with hot, dry skin, no perspiration, and a clouded mind, that is heat stroke, a life-threatening emergency demanding immediate aggressive cooling. The absence of sweating combined with altered mental status is the alarm that separates it from milder heat exhaustion. Question 30. A nurse is preparing a client who has atrial fibrillation of unknown duration for a scheduled cardioversion. The client has not received anticoagulation therapy. Which of the following actions should the nurse take? Your options are A. Proceed with the cardioversion as scheduled. B. Administer atropine before the shock. C. Withhold oxygen during the procedure. D. Notify the provider before the procedure. Which would you go with? Lock it in before the reveal. The correct answer is D. Notify the provider before the procedure. D is correct because atrial fibrillation of unknown duration requires several weeks of anticoagulation before cardioversion to prevent dislodging a clot. Lacking this therapy, the nurse should notify the provider because of the stroke and embolism risk. A is wrong because going ahead without prior anticoagulation could shake loose an atrial clot, sending it to the brain or lungs. Proceeding as scheduled ignores the embolism danger that makes provider notification the correct step here. B is wrong because atropine treats symptomatic bradycardia, not atrial fibrillation awaiting cardioversion. Giving it does nothing about the unaddressed clot risk, which is the real concern that should prompt the nurse to contact the provider. C is wrong because oxygen is actually provided during cardioversion preparation, not withheld. The pressing issue is the missing weeks of anticoagulation, an embolism hazard that withholding oxygen would neither cause nor solve. Atrial fibrillation causes the upper chambers of the heart to quiver rather than squeeze, which allows blood to pool and form clots. Cardioversion resets the rhythm with an electrical shock, but that success can become dangerous if a clot is present. While the atria quiver, blood stagnates along the chamber walls and a clot quietly builds. The moment cardioversion restores forceful contractions, that clot can be launched into the circulation and travel to the brain, causing a stroke. The danger is highest when atrial fibrillation has lasted more than 2 days, or its duration is unknown, and the patient has received no anticoagulation. Proceeding in this situation risks flinging a clot directly into the brain. The safeguard is anticoagulation for several weeks beforehand, or a transesophageal echocardiogram confirming no clot is present. Anticoagulation continues after the procedure as well. If neither safeguard is in place and duration is unknown, the nurse holds the procedure and notifies the provider. The critical distinction is emergency defibrillation versus elective cardioversion. A pulseless chaotic rhythm is shocked at once. No time for blood thinners. But a planned conversion of atrial fibrillation demands clot protection first. When that protection is missing, the procedure waits. Question 31. A nurse is caring for a client who is at risk for increased intracranial pressure following a head injury. Which of the following actions should the nurse take? Your options are: A. Administer a prescribed stool softener. B. Suction the airway frequently. C. Position the head on 2 pillows. D. Encourage a large oral fluid intake. Don't overthink it. Which one feels right? The correct answer is A. Administer a prescribed stool softener. A is correct because a stool softener prevents straining during bowel movements, which would trigger a Valsalva maneuver and raise intracranial pressure. Avoiding the strain helps keep the pressure controlled in a client who is already at risk after a head injury. B is wrong because frequent suctioning raises intracranial pressure by stimulating coughing and gagging. Rather than helping, this action would worsen the very pressure the nurse is trying to limit, so it should be kept to a minimum in this client. C is wrong because stacking 2 pillows hyperflexes the neck, which obstructs venous drainage from the head and increases intracranial pressure. The head should stay midline and neutral with the bed raised, not propped forward into flexion as this option describes. D is wrong because encouraging large fluid intake risks overhydration, which can increase cerebral edema and intracranial pressure. Fluids are given carefully to maintain perfusion while avoiding the excess volume that would aggravate the swelling already threatening the brain here. When the brain is injured, understanding intracranial pressure becomes critical. The skull is a rigid, sealed box, and everything inside it. Brain tissue, blood, and cerebrospinal fluid shares a fixed, unyielding space. Because bone cannot stretch, any increase in volume, swelling brain tissue, a bleed, or extra fluid, raises pressure on the brain itself. As pressure climbs, blood supply gets choked off, and in the worst case, brain tissue is forced downward through the skull's only opening, a deadly event called herniation. 3 major drivers of rising intracranial pressure are excess fluid, bleeding or swelling, and the Valsalva maneuver. The Valsalva, that bearing down strain against a closed airway, raises chest and abdominal pressure, backs up venous drainage from the head, and causes a sudden dangerous spike. Protective care means removing every possible trigger for a pressure spike. A stool softener prevents straining on the toilet, eliminating the Valsalva spike entirely. Frequent suctioning causes coughing that raises pressure, and neck flexion blocks venous drainage. Both push pressure in the wrong direction. On an exam, the signal is any patient at risk for increased intracranial pressure where a protective action is needed. Preventing the strain of constipation with a stool softener is one of the clearest and most testable ways to guard against a pressure surge. Question 32. A nurse is caring for a client who has an arteriovenous fistula in the left arm for hemodialysis. Which of the following actions should the nurse take? Your options are A. Draw blood samples from the fistula arm. B. Avoid blood pressure in that arm. C. Start an IV in that forearm. D. Apply a tight dressing over the fistula. Got a guess? Lock it in. The correct answer is B. Avoid blood pressure in that arm. B is correct because blood pressure measurement, venipuncture, and IV insertion are avoided in the fistula arm to protect the access from damage and clotting. Keeping that arm free of pressure and needle sticks preserves the lifeline the client needs for dialysis. A is wrong because drawing blood from the fistula arm risks clotting and injury to the access. Samples should be taken elsewhere, so using this arm for venipuncture endangers the very access the client depends on for treatment. C is wrong because starting an IV in the fistula arm threatens the access with infection and clotting. The unaffected arm should be used for intravenous lines, so placing one in the fistula forearm violates a basic protective rule. D is wrong because a tight dressing can compress the fistula and impair the blood flow that keeps it patent. The access needs an audible bruit and palpable thrill, which constriction would compromise, so this action risks losing the fistula. An arteriovenous fistula is a surgically created artery-to-vein connection that gives dialysis patients reliable, high-flow blood access. Because so much depends on it, protecting that fistula becomes a clinical priority every single day. The surgeon joins the artery directly to a vein, forcing it to enlarge and toughen over weeks. The result is a thick, high-flow vessel you can feel as a thrill and hear as a bruit, signs that flow is intact. The fistula arm is shielded from 4 threats: no blood pressure cuff, no blood draws, no intravenous lines, and no needle sticks of any kind. Every one of these compresses or punctures the vessel, risking clot or infection. A blood pressure cuff inflates and stops flow long enough to trigger clotting. A needle in the wrong site risks both clot and infection. Any compression, tight clothing, jewelry, or a dressing does the same damage as a cuff. On an exam, whenever a patient has an AV fistula or graft, that arm is off limits for pressures, draws, and lines. All routine procedures shift to the opposite arm, and confirming the thrill and bruit confirms the access is still working. Question 33. A nurse is assessing a client who has a head injury. Which of the following findings should the nurse identify as an indication of increased intracranial pressure? Your options are A. Tachycardia, B. Hypertension, C. Constricted reactive pupils. D. Decorticate posturing. Which one is it? Pause the video if you need more time. The correct answer is D. Decorticate posturing. D is correct because decorticate posturing, with adduction of the arms and flexion of the elbows and wrists, signals deteriorating motor function from increased intracranial pressure. This abnormal posture accompanies declining consciousness and pupillary changes as the pressure within the skull rises. A is wrong because increased intracranial pressure produces bradycardia, not tachycardia, as part of Cushing's triad. A slowing heart rate, rather than a fast one, accompanies the rising pressure, so tachycardia actually points away from this developing complication in the client. B is wrong because rising intracranial pressure causes hypertension with a widening pulse pressure rather than hypertension. The blood pressure climbs as a late compensatory response, so a low pressure does not signal this developing emergency the nurse is watching for here. C is wrong because pupils that constrict and react briskly are a normal, reassuring finding. Rising pressure within the skull instead compresses cranial nerves and produces dilated or pinpoint non-reactive pupils, so this intact response does not signal the developing emergency at all. When intracranial pressure climbs inside the fixed skull, the brain responds in predictable ways. Recognizing these warning signs early can make the difference between timely intervention and irreversible damage. Pressure on the brain announces itself through 4 categories of signs. Consciousness falls first, as it is the most sensitive indicator. Pupil dilation and sluggish light response follow. Deep damage forces the limbs into abnormal postures, and the late brainstem response produces Cushing's triad. 2 posturing patterns signal serious deterioration. Decorticate posturing flexes the arms toward the chest with curled wrists, while the legs extend. Decerebrate posturing is worse. The arms extend rigidly and rotate outward, reflecting deeper damage to the motor pathways. The late brainstem response to mounting pressure is Cushing's triad. Blood pressure rises with a widening pulse pressure, heart rate slows rather than speeds up, and breathing becomes irregular. This triad is an ominous late warning that the brainstem itself is being compressed. The most tested confusion is the direction vital signs move. Shock drops blood pressure and speeds the heart. Rising intracranial pressure does the opposite. It lifts blood pressure and slows the heart. Dilated sluggish pupils and abnormal posturing confirm RCP, not shock. Question 34. A nurse is monitoring a client on a cardiac unit who suddenly develops ventricular fibrillation. Which of the following interventions should the nurse anticipate for this client? Your options are A. Oral antidysrhythmic medication. B. Elevating the lower extremities. C. Immediate defibrillation. D. Withholding chest compressions. Take a second. Which answer would you pick? The correct answer is C. Immediate defibrillation. C is correct because ventricular fibrillation causes loss of consciousness, pulselessness, and no breathing, and it requires immediate defibrillation using ACLS protocol. Prompt electrical therapy is the key intervention for this shockable rhythm. A is wrong because an oral antidysrhythmic cannot work fast enough and is inappropriate in arrest. Emergency catecholamines are given IV, not by mouth, because the oral route is far too slow for a pulseless rhythm. B is wrong because elevating the legs is a measure for shock, not for a lethal rhythm. Ventricular fibrillation demands immediate defibrillation and CPR, so repositioning the extremities would only waste precious time during a life-threatening pulseless emergency. D is wrong because withholding chest compressions would abandon the CPR that sustains perfusion until and after a shock. Compressions are central to managing ventricular fibrillation, so stopping them endangers the client. Ventricular fibrillation is the most common shockable form of cardiac arrest. The ventricles stop pumping and quiver chaotically, cutting off all circulation within seconds. In ventricular fibrillation, the normal organized electrical signal collapses into a chaotic storm. The ventricles quiver instead of contracting, so no blood reaches the brain or body. Brain cells begin to die within minutes once circulation stops. The fibrillating heart cannot reset itself. Within seconds the pulse is gone, and within minutes permanent brain damage begins. An external intervention is the only way to restore a normal rhythm. The response pairs continuous chest compressions with prompt defibrillation. Compressions keep oxygenated blood moving to the brain while the defibrillator is prepared. Any medications are given by vein. Nothing oral, because a pulseless patient cannot absorb a swallowed drug fast enough. Examiners test whether you can separate arrest care from shock care. Immediate defibrillation and uninterrupted compressions are the correct picture. Elevating the legs belongs to circulatory shock, not arrest. Oral medications and pausing compressions are never correct. They waste the only window available to save the patient. Question 35. A nurse is preparing to assist with an arterial blood gas draw from a client's radial artery. Which of the following actions should the nurse take before the puncture? Your options are: A. Perform the Allen's test. B. Place the specimen at room temperature. C. Position the client in Trendelenburg. D. Apply a warm compress to the wrist. Before I reveal it, which one do you think is right? The correct answer is A. Perform the Allen's test. Is correct because the Allen's test confirms that both the radial and ulnar arteries supply the hand. A pink hand within seconds shows collateral circulation, so the radial artery can be punctured safely without risking ischemia. B is wrong because leaving an ABG sample at room temperature lets blood cells keep consuming oxygen, which falsely alters the results. The capped specimen belongs in ice water and must go to the lab right away to stay accurate. C is wrong because placing the client head down in Trendelenburg suits hypertension or central line insertion, not a wrist puncture. Radial sampling needs only a supported extended wrist, so this position adds nothing and is unnecessary here. D is wrong because warming the wrist is not part of radial ABG sampling. The key safety step is verifying dual arterial supply through the Allen's test, something a compress cannot accomplish or replace before the needle goes in it. Before drawing blood from the radial artery, clinicians must confirm the hand has a backup blood supply. This safeguard is called the Allen's test, and it comes before any puncture is made. Most hands receive blood from two sources, the radial artery on the thumb side and the ulnar artery on the little finger side. These two vessels connect through a palmar arch, meaning if the radial artery is damaged, the ulnar artery can keep the hand alive on its own. To perform the test, the examiner compresses both the radial and ulnar arteries while the patient clenches a fist, draining the hand pale. The ulnar artery is then released. If the hand flushes pink within seconds, collateral flow is adequate and the radial artery can be safely punctured. The Allen's test protects the patient's hand before the puncture by confirming a second blood supply exists. Icing the sample protects the accuracy of results afterward. These are easy to confuse on an exam, but only the Allen's test is required before the needle goes in. Whenever a question describes preparation for a radial arterial blood gas and asks what must happen first, the answer is the Allen's test, confirming the ulnar artery can supply the hand if the radial one fails. Question 36. A nurse is assessing a client who has cirrhosis and a rising ammonia level. Which of the following findings indicates the client is developing hepatic encephalopathy? Your options are: A. Yellowing of the skin and sclera. B. Asterixis and a change in orientation. C. Distended abdomen from ascites. D. Decreased appetite and fatigue. What's your answer? Commit to one before I continue. The correct answer is B. Asterixis and a change in orientation. B is correct because rising ammonia in cirrhosis produces asterixis, fetor hepaticus, and changes in orientation, the markers of hepatic encephalopathy. These neurologic signs prompt treatment with lactulose, so the nurse recognizes them as the developing complication. A is wrong because jaundice reflects impaired bilirubin handling in liver disease, but is not specific to encephalopathy. While it signals liver dysfunction, it does not indicate the ammonia-driven neurologic changes that define this particular complication. C is wrong because a CT's results from portal hypertension and low albumin, a manifestation of liver failure rather than encephalopathy. A distended abdomen shows fluid shifting, not the altered mental status and asterixis the nurse is screening for. D is wrong because anorexia and fatigue are general features of liver dysfunction seen across many stages. They lack the specificity of asterixis and disorientation, so they do not by themselves signal the onset of hepatic encephalopathy. Hepatic encephalopathy is a brain syndrome caused by liver failure, most often seen in cirrhosis. When the liver can no longer filter the blood, ammonia and other toxins accumulate and cross into the brain, disrupting how it functions. In a healthy liver, ammonia, a waste product of protein breakdown, is cleared before it can reach the brain. In cirrhosis, scarred tissue fails to process it, and blood may even bypass the liver entirely through collateral vessels, sending ammonia straight to the brain. The hallmark findings center on the nervous system. Asterixis, a flapping tremor seen when the wrists are extended, is the most specific sign. Early on, patients show subtle disorientation and personality changes. As ammonia rises further, drowsiness deepens towards stupor and coma. The key distinction examiners test is separating the brain syndrome from other features of liver disease. Jaundice reflects bilirubin buildup, and ACIT reflects portal hypertension and fluid shifts. Both are signs of liver dysfunction, but neither marks the brain involvement. Only asterixis and disorientation point specifically to hepatic encephalopathy. When you see cirrhosis with a rising ammonia level, look for the flapping tremor and altered orientation. Those two findings define hepatic encephalopathy and separate it from the jaundice and fluid buildup of the underlying disease. Treatment with lactulose aims to clear ammonia through the bowel before the mental state worsens. Question 37. A nurse is caring for a client who has been vomiting for an extended period. Which of the following acid-base imbalances should the nurse anticipate? Your options are A. Metabolic acidosis, B. Respiratory acidosis, C. Respiratory alkalosis, D. Metabolic alkalosis. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Metabolic alkalosis. D is correct because prolonged vomiting causes loss of gastric acid and a resulting accumulation of bicarbonate, producing metabolic alkalosis. Treatment targets the underlying cause with antiemetics and careful replacement of the lost fluids and electrolytes. A is wrong because metabolic acidosis develops from a low bicarbonate, as seen with diarrhea or ketoacidosis. Vomiting instead removes acid and raises the bicarbonate level, so it drives the imbalance in the opposite, alkalotic direction. B is wrong because respiratory acidosis arises from hyperventilation and retained carbon dioxide, a lung problem. Vomiting alters bicarbonate through gastric acid loss, not carbon dioxide, so this respiratory disorder does not apply. C is wrong because respiratory alkalosis comes from hyperventilation that lowers carbon dioxide through the lungs. Because the imbalance from vomiting involves bicarbonate rather than breathing, This carbon dioxide-driven disorder does not fit the scenario described. Metabolic alkalosis is an acid-base disturbance where the blood becomes too alkaline, marked by a high pH and elevated bicarbonate. Prolonged vomiting is one of its most classic causes, and understanding why requires looking at where the body's acid actually lives. The stomach is the body's reservoir of hydrochloric acid. Every vomiting episode carries that acid out of the body. As acid drains away, bicarbonate, normally balanced against it, accumulates in relative excess, pushing blood pH upward. Vomiting also strips away fluid, chloride, and potassium. These losses signal the kidneys to retain bicarbonate and excrete even more acid in the urine, deepening the alkalosis rather than correcting it. The imbalance is both created by lost stomach acid and sustained by the kidney's response. Vomiting maps to metabolic alkalosis, not to any of the other three states. Metabolic acidosis comes from losing bicarbonate-rich fluid, as in diarrhea. Respiratory acidosis and respiratory alkalosis are both lung-driven, caused by retaining or blowing off carbon dioxide, which vomiting does not affect. The clinical rule is clean. Losing acid from above through vomiting raises pH into alkalosis, while losing bicarbonate-rich fluid from below through diarrhea lowers pH into acidosis. When you see prolonged vomiting, anticipate metabolic alkalosis and treat with fluid and electrolyte replacement. Question 38. A nurse is preparing to administer insulin aspart to a client who has diabetes mellitus. Which of the following actions should the nurse take? Your options are: A. Give it 1 hour before eating. B. Give it at bedtime with food. C. Give it when the tray arrives. D. Give it after the meal ends. Which would you go with? Lock it in before the reveal. The correct answer is C. Give it when the tray arrives. C is correct because insulin aspart is rapid acting, so it is given just before eating, when the meal tray arrives. Timing the dose with food matches the quick onset and prevents hypoglycemia from acting before the client has eaten. A is wrong because giving rapid-acting insulin a full hour before the meal risks hypoglycemia before food is available. The quick onset means it should be timed with the meal, so dosing this early misjudges the drug's action. B is wrong because bedtime dosing with a snack fits a longer-acting insulin, not a rapid-acting one tied to meals. Administering aspart at night ignores its mealtime purpose, so this timing is incorrect for the medication. D is wrong because rapid-acting insulin is given just before eating rather than after the meal is done. Waiting until afterward leaves the glucose rise uncovered at its peak, so this delayed timing does not match how aspart works. Insulin aspart is a rapid-acting insulin engineered to cover the blood sugar rise that comes with eating. Understanding why timing this dose to the meal matters requires knowing how rapid-acting insulins work, and how they differ from other insulin types. Insulin aspart begins working within about 15 minutes, peaks around 1 hour, and clears within a few hours. This fast onset is designed to match the quick rise in blood glucose that follows a meal, mimicking the natural insulin burst a healthy pancreas would release. Because the insulin starts lowering blood sugar within minutes of injection, it must be given when food is actually about to be eaten. Administering it too early, before food is available, allows the insulin to drive blood sugar down before any glucose arrives to balance it, causing dangerous hypoglycemia. The correct approach is to give insulin aspart just as the meal tray arrives and the patient is confirmed ready to eat. Giving it a full hour early risks hypoglycemia. Giving it after the meal misses the glucose peak it is meant to cover. The key distinction to remember is that rapid-acting insulins like aspart are always timed to food, while long-acting basal insulins follow a steady schedule independent of meals. On an exam, when you see a rapid-acting insulin, pair it with the meal. Question 39. A nurse is caring for a client who remains severely hypoxemic despite receiving high concentrations of oxygen and has bilateral infiltrates on a chest X-ray. Which of the following conditions should the nurse suspect? Your options are A. Chronic bronchitis exacerbation, B. Acute respiratory distress syndrome, C. Spontaneous pneumothorax, D. Acute sinusitis. Don't overthink it. Which one feels right? The correct answer is B. Acute respiratory distress syndrome. B is correct because severe hypoxemia that persists despite high oxygen concentrations, combined with diffuse bilateral infiltrates, is characteristic of acute respiratory distress syndrome. Injured alveolar membranes leak fluid and lose surfactant, so oxygen alone cannot correct the deficit. A is wrong because a chronic bronchitis flare narrows airways and increases mucus, but typically responds to oxygen and bronchodilators. It does not produce the refractory hypoxemia and diffuse bilateral infiltrates that define the syndrome on imaging. C is wrong because a spontaneous pneumothorax shows a one-sided collapsed lung with absent breath sounds, not bilateral infiltrates. Its hypoxia often improves with decompression, unlike the membrane injury picture that resists even maximal oxygen. D is wrong because acute sinusitis is an upper airway inflammation causing facial pain and congestion, with no effect on alveolar gas exchange. It cannot account for life-threatening hypoxemia or the widespread lung infiltrates described here. Acute respiratory distress syndrome is a sudden, severe lung failure where the tiny air sacs flood with fluid, blocking oxygen from reaching the blood. It's defined by two hallmarks that set it apart from other lung conditions: a severe insult, sepsis, trauma, aspiration, or pancreatitis injures the delicate alveolar membrane. The membrane becomes leaky, fluid pours in from the bloodstream, and surfactant-producing cells are damaged, causing the sacs to collapse. Extra oxygen delivered to the airway never reaches the blood. The two defining features are refractory hypoxemia, oxygen that stubbornly refuses to rise even with high concentrations, and bilateral infiltrates on the chest film, the radiographic shadow of widespread flooding across both lungs. Other conditions cause breathlessness but behave differently. A bronchitis flare narrows airways but typically responds to oxygen and bronchodilators. A pneumothorax collapses one lung with absent sounds on that side, not diffuse bilateral flooding. Neither shows the refractory hypoxemia that marks ARDS. On any exam, when you see severe hypoxemia that persists despite high oxygen paired with diffuse bilateral infiltrates, the answer is ARDS. Oxygen alone cannot solve it. Ventilatory support and treating the underlying cause are required. Question 40. A nurse is assessing a client who has a diagnosis of osteoarthritis. Which of the following findings should the nurse expect to identify in this client? Your options are A. Heberdin's nodes on the fingers, B. Symmetrical swelling of all joints, C. A small underweight frame, D. A positive rheumatoid factor. Got a guess? Lock it in. The correct answer is A. Heberdin's nodes on the fingers. A is correct because Heberdin's nodes at the distal interphalangeal joints are characteristic of osteoarthritis, reflecting bony enlargement from cartilage deterioration. These nodes accompany crepitus, joint pain with activity, and asymmetrical joint involvement in this degenerative, non-inflammatory disorder of the joints. B is wrong because symmetrical swelling of all joints points to rheumatoid arthritis, an inflammatory and systemic disease. Osteoarthritis is degenerative and localized. affecting the joints asymmetrically rather than producing the widespread, symmetrical pattern that the other arthritis condition characteristically causes in clients. C is wrong because clients with osteoarthritis are usually overweight, since the excess weight stresses the weight-bearing joints over time. A small, underweight frame is more typical of rheumatoid arthritis, so this body type simply does not fit the usual osteoarthritis presentation here. D is wrong because a positive rheumatoid factor supports a diagnosis of rheumatoid arthritis, not osteoarthritis. Laboratory results in osteoarthritis are usually normal because the process is mechanical cartilage breakdown rather than the immune-mediated systemic illness that produces that antibody finding. Osteoarthritis is a degenerative disease, not an immune attack, but a gradual mechanical wearing away of the cartilage that cushions the ends of bones. Understanding the structural changes it causes explains every sign and symptom that follows. As cartilage erodes over years, bone grinds against bone. The body responds by laying down extra bone at the joint margins, forming osteophytes, the hard spurs and knobs that define the disease structurally. The pattern is mechanical and localized. Pain worsens with activity and eases with rest. Joint involvement is typically asymmetrical, and laboratory tests run normal because there is no systemic inflammation. On the hands, bony enlargements form at predictable sites. Heberdin's nodes appear at the joints nearest the fingertips, Bouchard's nodes at the middle joints, and a grating sensation called crepitus can be felt as the roughened surfaces move against each other. The critical distinction is separating osteoarthritis from rheumatoid arthritis. Osteoarthritis is asymmetrical with normal labs and bony Heberdin's nodes. Rheumatoid arthritis is symmetrical, systemic, and carries a positive rheumatoid factor. Activity-related pain and bony nodes always point to the degenerative disease. Question 41. A nurse is caring for a client who has colon cancer that has spread to the liver. Which of the following statements about this client's cancer is accurate? Your options are: A, it is now primary liver cancer. B, it is treated based on liver cells. C, it is named metastatic colon cancer. D, the liver tumor is considered benign. Which one is it? Pause the video if you need more time. The correct answer is C. It is named metastatic colon cancer. C is correct because cancer is named for its tissue of origin even after it spreads. So colon cancer that travels to the liver is metastatic colon cancer. Treatment is based on the original colon cells, not the site of spread. That is wrong because the disease keeps the identity of its origin. So spread to the liver does not make it primary liver cancer. Relabeling it by the new location ignores the rule that cancer is named for where it began. B is wrong because treatment follows the cell of origin, which is the colon, not the liver where the tumor landed. Basing therapy on liver cells would target the wrong cell type and misdirect the chosen treatment regimen. D is wrong because a tumor that has spread from the colon is malignant, not benign, because benign growths do not invade or metastasize. Calling the liver lesion benign contradicts the very fact that it traveled from another organ. Cancer keeps the name of the tissue where it first arose, even after it spreads to a completely different organ. This principle of naming by origin is one of the most fundamental ideas in oncology. In metastasis, cancer cells break away from the primary tumor, travel through blood or lymph vessels, and establish secondary tumors at a new site. When colon cancer cells land in the liver, they are still colon cells. They look like colon tissue under a microscope and carry colon cancer biology. The site where cancer lands does not rewrite what it is. A colon cancer cell in the liver still looks like colon tissue, carries colon cell genetics, and responds to treatments designed for colon cancer, not liver cancer. A primary tumor arises in its own tissue. A secondary metastatic tumor is that same cancer relocated. Calling colon cancer in the liver A primary liver cancer is wrong. It targets the wrong cell type entirely. And any tumor that has metastasized is malignant by definition, never benign. When a cancer spreads, it keeps the name and treatment of where it started. Colon cancer in the liver is metastatic colon cancer, diagnosed and treated as such always. Question 42. A nurse is reinforcing teaching with a client who has a new prescription for sucralfate to treat a peptic ulcer. Which of the following instructions should the nurse include? Your options are: A. Take it immediately after each meal. B. Crush the tablet into food. C. Take an antacid at the same time. D. Take the medication on an empty stomach. Take a second. Which answer would you pick? The correct answer is D. Take the medication on an empty stomach. D is correct because sucralfate coats the ulcer to form a protective barrier and works best on an empty stomach, about 1 hour before meals. Taking it without food present lets the medication adhere directly to the eroded mucosa. A is wrong because taking the drug right after eating places food between the medication and the ulcer surface. Sucralfate needs an empty stomach to bind the lining, so dosing after meals undermines the protective coating it forms. B is wrong because this medication is meant to coat the gastric lining as a barrier, and crushing it into food interferes with that action. The tablet works locally on an empty stomach, not blended into a meal. C is wrong because antacids should be separated from sucralfate because giving them together reduces the binding that creates the protective layer. Combining the two at once defeats the spacing the regimen requires for the coating to work. Sucralfate treats peptic ulcers in a fundamentally different way than acid-reducing medications. Instead of changing the body's chemistry, it works locally, forming a physical protective layer directly on the ulcer surface. When sucralfate reaches the acidic stomach, it converts into a thick, sticky paste that binds tightly to the raw, damaged tissue of the ulcer. This coating shields the wound from acid and digestive enzymes, letting the lining heal beneath it. Because sucralfate must reach bare ulcer tissue, timing is critical. On an empty stomach, the paste adheres directly to the ulcer. Food gets in the way and blocks adhesion. Antacids blunt the acid activation the drug relies on to form its paste. Unlike acid reducers, which work throughout the body and can be taken around food, sucralfate must reach a bare ulcer surface. It is taken about an hour before meals and at bedtime, and any antacid must be spaced apart to preserve the acid environment needed for activation. When an exam question mentions sucralfate for a peptic ulcer and asks about correct instructions, the answer centers on an empty stomach before meals and separating antacids. That empty stomach is what lets the protective coating reach and seal the ulcer. Question 43. A nurse is reinforcing teaching with a client who has glaucoma and a new prescription for timolol ophthalmic drops. Which of the following adverse effects should the nurse instruct the client to report? Your options are: A. Increased appetite and weight gain. B. Reddening and darkening of the iris. C. A slow heart rate and trouble breathing. D. Excessive tearing and watery eyes. Before I reveal it, which one do you think is right? The correct answer is C. A slow heart rate and trouble breathing. C is correct because timolol is a beta blocker that can be absorbed systemically, causing bradycardia, hypotension, and bronchoconstriction. The client should report a slow heart rate or trouble breathing, especially given the caution required in asthma or chronic lung disease. A is wrong because increased appetite and weight gain are not effects of this beta blocker. Timolol's systemic concerns involve the heart and lungs, so directing the client to watch for appetite changes would miss its true adverse profile and dangers. B is wrong because darkening of the iris is associated with prostaglandin analogues used for glaucoma, not with timolol. The client has confused a pigment change from a different drug class with the cardiopulmonary effects that the beta blocker actually causes here. D is wrong because mild eye stinging can occur, but excessive tearing is not the priority systemic effect to report. The serious risks of timolol are the slow heart rate and bronchospasm that genuinely threaten the heart and the client's breathing. Timolol is a beta blocker used as eye drops to treat glaucoma by reducing fluid production and lowering pressure inside the eye. What makes it clinically important is that a drug placed in the eye can affect the entire body. The eye is not a sealed compartment. Drops drain through the tear ducts into the nose and throat, where the rich blood supply absorbs the drug into the general circulation. Once there, timolol acts as a beta blocker everywhere. In the heart, beta blockade slows the rate and lowers blood pressure, causing bradycardia. In the lungs, it constricts the airways and can trigger bronchospasm, a serious danger for patients with asthma or chronic lung disease. The key distinction: timolol causes bradycardia and bronchospasm, not iris darkening. That belongs to prostaglandin analogues, a different drug class entirely. On an exam, slow heart rate or breathing trouble points to systemic beta blockade from timolol. Pressing on the inner corner of the eye after each dose, punctal occlusion, limits how much drug drains into the bloodstream. Patients must report a slow pulse, dizziness, or new difficulty breathing, as these are the systemic effects that genuinely threaten safety. Question 44. A nurse is reinforcing teaching with a client who has psoriasis. Which of the following statements by the client indicates understanding of skin care? Your options are: A. I will scrub the scales off. B. I will leave the scales in place. C. I will apply the steroid cream facially. D. I will use the cream continuously. What's your answer? Commit to one before I continue. The correct answer is B. I will leave the scales in place. B is correct because removing psoriasis scales can cause bleeding, so the client is taught to leave them in place. Recognizing that scales should not be picked or scrubbed off shows correct understanding of safe skin care. A is wrong because scrubbing the scales off injures the skin beneath and triggers bleeding, which the teaching specifically warns against. Choosing to remove them shows the client has not grasped why the scales are left undisturbed. C is wrong because topical corticosteroids are avoided on the face and skin folds because the thin skin there is prone to thinning and yeast overgrowth. Applying the cream to the face disregards this precaution and could damage delicate tissue. D is wrong because steroid creams require periodic medication vacations to prevent skin thinning and striae, rather than continuous use. Keeping the cream on the same area without breaks reflects a misunderstanding of safe application of the medication. Psoriasis is a chronic immune-driven skin disease, not an infection, and not caused by poor hygiene. Understanding how to care for it properly starts with understanding why those silvery scales form in the first place. Normally the skin replaces itself over about a month. In psoriasis, immune signals tell the skin to grow as if healing a wound, even when there is no wound. So cells pile up far faster than they can shed, forming the characteristic thick plaques. The plaques form where excess skin cells have stacked up beneath a surface layer of silvery scale. Just under that scale, the skin is thickened but also fragile, and blood vessels run close to the surface, which is exactly why disturbing the scales causes bleeding. Safe care follows three principles. Keep the skin well moisturized. Leave the scales undisturbed rather than scrubbing or picking them off, and use prescribed steroid creams in planned intervals, avoiding continuous use and never applying potent steroids to the thin skin of the face. When you see psoriasis on an exam, the correct answer centers on gentle protective handling. disturbing the scales, tears fragile skin, can cause bleeding, and may trigger new plaques at the injury site. So the goal is always to protect the skin, not strip it. Question 45. A nurse is caring for a client who has a suspected dissecting abdominal aortic aneurysm and reports sudden, tearing back pain with diaphoresis and faintness. Which of the following actions should the nurse take first? Your options are: A. Administer intravenous fluids. B. Give the prescribed pain medication. C. Apply warm blankets to the client. D. Obtain an ECG. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Administer intravenous fluids. A is correct because a dissecting aneurysm threatens circulatory volume through leakage and fluid shifts, so the nurse administers IV fluids first. Supporting perfusion under circulation priorities takes precedence over pain relief, warming, or obtaining an ECG. B is wrong because pain medication is needed but does not address the threatened circulatory volume from a dissecting aneurysm. Maintaining perfusion with IV fluids comes first, since hemodynamic support outranks comfort when the client risks inadequate volume. C is wrong because warm blankets provide comfort but do nothing for the perfusion threat of a leaking dissection. The priority is supporting circulating volume with IV fluids, so warming the client cannot be the first action in this emergency. D is wrong because an ECG yields useful data but delays the immediate intervention of restoring circulatory volume. With a dissecting aneurysm risking inadequate perfusion, administering IV fluids takes priority over obtaining the tracing first. A dissecting aortic aneurysm occurs when blood forces through a tear in the aorta's inner wall, splitting the vessel layers apart. This is a life-threatening emergency because the leaking blood drains the body's circulating volume, pushing the patient toward hypovolemic shock. The aorta has 3 wall layers. When the innermost layer tears, blood drives between the layers, creating a false lumen alongside the true one. The splitting progresses along the artery's length, causing the hallmark sudden, severe tearing pain felt in the back. Unlike a stable aneurysm that is simply monitored, a dissection is actively progressing. Blood escaping into the wall reduces the effective circulating volume, and without enough volume to perfuse the brain, heart, and organs, the patient deteriorates rapidly toward hypovolemic shock. Care is ranked by the circulation first principle. Establishing intravenous access and running fluids directly addresses the falling volume and is the first action. Blood pressure management follows closely to reduce wall stress. Pain medication and diagnostic steps like an ECG matter, but perfusion outranks comfort and data collection. When a dissecting aneurysm threatens circulating volume, support that volume first. IV fluids come before pain relief, warming, or tracing the heart, because the patient needs perfusion to keep the organs alive while definitive treatment is arranged. Question 46. A nurse is reinforcing teaching with a client who has a benign brain tumor. Which of the following statements by the client indicates an understanding of the teaching? Your options are: A. This tumor will travel to my lungs. B. This tumor came from another cancer. C. Chemotherapy will easily reach it. D. This tumor will not spread elsewhere. Which would you go with? Lock it in before the reveal. The correct answer is D. This tumor will not spread elsewhere. D is correct because a benign brain tumor develops from the meninges or cranial nerves, has distinct boundaries, and does not metastasize. It stays limited to brain tissue, causing harm by pressure rather than by spreading to other areas of the body. A is wrong because benign tumors do not metastasize, so they do not travel to distant organs like the lungs or liver. That pattern of distant spread describes malignant disease, not the contained, well-bordered growth that this client actually has at present. B is wrong because a tumor arriving from cancer elsewhere is a secondary metastatic lesion, which is malignant by definition. A benign primary brain tumor originates within the cranial structures and is not seeded from another site somewhere else in the body. C is wrong because the blood-brain barrier can block chemotherapy from reaching brain tumors in adequate doses, so the drug does not pass easily. This statement misrepresents both the tumor's nature and how medication penetrates the protected tissue of the brain. When a tumor is described as benign, that single word tells you something critical about how it behaves. Understanding the difference between benign and malignant comes down to one core ability: the capacity to spread. A benign tumor stays where it started. It does not invade nearby tissue. It does not send cells through the blood or lymph to seed new tumors elsewhere. And it grows within clear, well-defined borders. Metastasis, that distant spread, is the defining danger of malignant cancer, and benign tumors simply lack that ability. In the brain, the skull leaves no room to spare. Even though a benign tumor will not spread, it can still cause serious harm by pressing on surrounding brain structures as it grows. The threat here is local pressure inside a closed space, not invasion or distant spread. The distinction is clean. Malignant tumors invade nearby tissue and metastasize to distant organs, while benign tumors stay localized and cause harm only through local pressure when space is confined. That single difference, the capacity to metastasize or not, separates the two categories. On any exam, when you see a benign tumor, the accurate statement is that it will not spread elsewhere. Harm from a benign brain tumor comes from crowding the brain inside the skull, a very different threat from the distant colonization that defines malignant cancer. Question 47. A nurse is caring for a client who develops itching and hives shortly after a transfusion begins, with stable vital signs otherwise. Which of the following medication should the nurse anticipate administering? Your options are A. Epinephrine, B. Diphenhydramine, C. Furosemide, D. An antibiotic. Don't overthink it. Which one feels right? The correct answer is B. Diphenhydramine. B is correct because itching and urticaria indicate a mild allergic transfusion reaction. After stopping the transfusion and maintaining saline through new tubing, the nurse anticipates an antihistamine such as diphenhydramine to counter the histamine-driven symptoms. A is wrong because epinephrine is reserved for anaphylaxis with bronchospasm, laryngeal edema, or shock. This client has only mild itching and hives without airway or circulatory collapse, so the powerful response of epinephrine is not yet warranted. C is wrong because furosemide manages circulatory overload, which presents with crackles, distended neck veins, and dyspnea from too much volume. It would do nothing for an allergic skin reaction that is driven by histamine release. D is wrong because an antibiotic addresses a bacterial reaction from contaminated blood marked by wheezing, hypertension, and shock. Hives and itching reflect allergy rather than infection, so antimicrobial therapy targets the wrong problem here. When a patient receives a blood transfusion, their immune system may react to foreign proteins in the donor plasma. Understanding why this happened and how to respond starts with histamine. The donor plasma contains proteins the recipient's immune system may treat as foreign. This triggers mast cells to release histamine, which causes small blood vessels to leak, producing the classic signs of itching and hives confined to the skin. The hallmark of a mild allergic reaction is that symptoms stay confined to the skin. Vital signs are stable, and there is no airway or circulatory trouble. This is what separates it from more dangerous reactions. Matching the right drug to the right reaction is the core exam skill. Diphenhydramine targets histamine-driven hives. Epinephrine is reserved for anaphylaxis with airway or pressure collapse. Furosemide addresses volume overload, and antibiotics cover bacterial contamination. Each reaction has a distinct clinical picture. When you see itching and hives shortly after a transfusion begins, with stable vital signs and no airway involvement, that is a mild allergic reaction. Stop the transfusion. Run saline through new tubing and reach for diphenhydramine to block the histamine driving the symptoms. Question 48. A nurse is assessing a client who has a small bowel obstruction and abdominal distension. Which of the following findings should the nurse expect when caring for this client? Your options are A. Significant low abdominal distension. B. Ribbon-like stools around an impaction. C. Projectile vomiting with a fecal odor. D. Absence of any abdominal pain. Got a guess? Lock it in. The correct answer is C. Projectile vomiting with a fecal odor. C is correct because a small bowel obstruction causes profuse projectile vomiting that may carry a fecal odor as contents backup. This finding, along with metabolic alkalosis from fluid loss, reflects the high blockage the nurse expects. A is wrong because marked low abdominal distension points to a large bowel obstruction rather than a small bowel one. The level of blockage differs, so this finding does not match the high obstruction described in the scenario. B is wrong because ribbon-like stools passing around an impaction occur with large bowel obstruction, not a small bowel blockage. This sign reflects a lower obstruction site, so it is not what the nurse would expect to find here. D is wrong because obstruction produces colicky, intermittent pain rather than no pain at all. Expecting a complete absence of discomfort overlooks a key feature of bowel blockage, so this finding is inconsistent with the condition. When the small intestine is blocked, the location of that blockage determines everything about how the patient looks and feels. Understanding why the small bowel produces such dramatic vomiting comes down to anatomy and pressure. The small bowel sits just past the stomach, so a blockage there leaves almost no room for contents to accumulate upstream. Pressure builds rapidly, and the stomach is the only exit, producing early, forceful, high-volume vomiting that can carry a foul fecal odor. The hallmarks follow directly from the high blockage. Vomiting is early and profuse because the backup reaches the stomach fast. The lost gastric acid drives a metabolic alkalosis, and the bowel contracting against the obstruction produces colicky, cramping pain in waves. Separating small bowel from large bowel obstruction is the key exam distinction. A high blockage means early vomiting with fecal odor and less abdominal distension. A low, large bowel blockage means marked lower distension and altered stool passage, with vomiting appearing much later. The higher the obstruction, the faster pressure reaches the stomach and the more dramatic the vomiting. Fecal-smelling projectile vomit with colicky pain and modest distension is the signature of a small bowel obstruction, and the finding to reach for on the exam. Question 49. A nurse is reinforcing teaching with a client who forms calcium oxalate stones. Which of the following foods should the nurse instruct the client to avoid? Your options are A. Skim milk and yogurt. B. White bread and pasta. C. Lean chicken and turkey. D. Spinach and black tea. Which one is it? Pause the video if you need more time. The correct answer is D. Spinach and black tea. D is correct because spinach and black tea are high in oxalate, which contributes to calcium oxalate stone formation. Avoiding these oxalate-rich foods helps lower the chance of forming new stones, so the nurse includes them in the teaching. A is wrong because milk and yogurt are limited with struvite stones because of their phosphate content, not with calcium oxalate stones. These dairy foods are not the oxalate sources targeted here, so they are the wrong foods to avoid. B is wrong because white bread and pasta are low in oxalate and not a concern for this stone type. They do not raise oxalate levels, so instructing the client to avoid them would misdirect the dietary teaching. C is wrong because lean poultry relates to purine restriction for uric acid stones rather than oxalate restriction. Since chicken and turkey are not high in oxalate, they are not the foods a client forming calcium oxalate stones should avoid. Kidney stones form when urine becomes so concentrated with certain minerals that they crystallize and grow into hard deposits. The most common type, calcium oxalate, builds up when oxalate and calcium reach levels the urine can no longer keep dissolved. When oxalate from food enters the urine and meets calcium, the two compounds combine and precipitate out as crystals. The seeds of a stone, the higher the oxalate concentration, the more the balance tips toward crystal formation. Cutting back on high oxalate foods directly lowers one of the two building blocks of the stone. Key sources to limit include spinach, black tea, rhubarb, beets, chocolate, nuts, and wheat bran. Prevention focuses on limiting oxalate intake and staying well hydrated so minerals stay dissolved. Importantly, drastically cutting calcium can backfire. Some dietary calcium binds oxalate in the gut and carries it out before it ever reaches the urine. A key exam skill is matching the stone type to the correct dietary restriction. Calcium oxalate stones call for limiting oxalate-rich foods. Uric acid stones require cutting purine-rich foods like organ meats, and struvite stones involve separate concerns entirely. Question 50. A nurse is caring for a client during the first hours after a kidney transplant. Which of the following findings should the nurse report to the provider immediately? Your options are A. Steadily decreasing hourly urine output. B. Pink-tinged urine that gradually clears. C. A urine output that is briskly increasing. D. A small amount of bloody wound drainage. Take a second. Which answer would you pick? The correct answer is A. A steadily decreasing hourly urine output. A is correct because after a transplant, the new kidney should produce a steady urine output. So a falling or scant output may signal rejection, thrombosis, or obstruction. Oliguria is not expected, so the nurse reports it immediately to protect the graft. B is wrong because urine that starts pink or bloody and gradually clears is the expected course after transplant surgery. This normal progression reflects healing rather than a complication, so it does not require urgent reporting to the provider. C is wrong because a rising urine output reflects the new kidney beginning to function, a reassuring sign. Although marked diuresis is watched for fluid loss, increasing output itself contrasts with the oliguria that truly demands immediate notification. D is wrong because a small amount of bloody drainage from the surgical wound is anticipated and assessed routinely. Unlike low urine output, minor expected drainage does not point to graft failure, so it lacks the urgency of oliguria. After a kidney transplant, urine output becomes the most immediate window into how the new kidney is functioning. A healthy transplanted kidney should produce a steady, often generous flow of urine soon after surgery. The transplanted kidney depends on three things staying intact: its blood supply through the renal vessels, its drainage through the ureter, and the body's acceptance of the graft. Any disruption to these will first show up as a change in urine output. The early post-transplant period carries the highest risk of graft-threatening complications. Rejection, arterial or venous thrombosis, and ureteral obstruction can all choke off kidney function, and each one announces itself first through a falling urine output. Not every abnormal-looking finding is dangerous. Pink urine that clears, a briskly increasing output, and small amounts of wound drainage are all part of normal healing. The one finding that demands immediate reporting is a steadily decreasing hourly urine output because it signals possible rejection, thrombosis, or obstruction. When urine output falls after a kidney transplant, that drop is abnormal and urgent. Reporting it right away gives the team the chance to find and fix the cause before the graft is lost.
You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.